Hello, my name is Jawad Amin. I'm a medical student here at Aachen University, and I'll be the moderator for the 11th session, which is clinical trials in neuro-oncology. So we have five speakers for this session: Dr. Vinay Pudwali, Dr. Patrick Quinn, Dr. Vijay Patel, Dr. Tejpal Gupta, and Dr. Rupesh Koteka. The chair for this session is Dr. Rakesh Jalali. Dr. Rakesh Jalali is the medical director of India's and South Asia's first proton therapy facility at the Advanced Comprehensive Cancer Center, the Apollo Proton Cancer Center. Before joining Apollo, Dr. Jalali spent 18 long years at Tata Memorial Hospital, Mumbai, where he led the Neuro-Oncology group as the finest such unit in India. Dr. Jalali played a major role in establishing the Indian Society of Neuro-Oncology in 2008, and he also founded the Brain Tumor Foundation of India, which is an internationally recognized Indian organization focusing on welfare of the patient with brain tumors and their families. The co-chair for this session is Dr. Pankaj Kumar Panda. Dr. Panda is currently the Senior Research Officer and Associate Professor at the South Asia's first proton therapy facility at the Apollo Hospital Group's Apollo Proton Cancer Center in Chennai. He completed his master's in clinical research from Tata Memorial Hospital, Mumbai, and worked as a medical research fellow at the Tata Memorial Hospital. He has been involved in several prospective clinical trials in surgical, medical, and radiation oncology, cancer epidemiological studies, and clinical audits. He is the faculty for the Australia and Asia Pacific Clinical Oncology Research Development Initiative in Sydney, Australia. So without taking any more time, I'll give this mic to the chair and co-chair.
Thank you very much for the very nice, kind introduction. I'd like to begin, along with my co-chair, Dr. Panda, our gratitude by placing our gratitude to Dr. Syed Athir Inam, as well as Dr. Naurin Mushtaq, as well as organizers of this wonderful Congress. I'll also take this opportunity to compliment and congratulate for carrying out yet another beautiful meeting and very educational. And so this session was also discussed at length with Athir. And this is an, I think, important, relevant session, particularly to our landscape in the subcontinent as well as in general LMICs, but also has resonance globally as well. So we have five outstanding speakers for this session, dwelling on different aspects of conducting relevant clinical trial research in neuro-oncology. And may I begin with inviting the first speaker, Dr. Vinay Pudwali. And Vinay is the director of the neuro-oncology program at MD Anderson Cancer Center, Houston, and has a very large experience in conducting several clinical trials. So I don't know whether he's live or he's going to give a recorded talk. So if the organizers have his recorded talk, may I request them to kindly start with Dr. Pudwali's presentation.
Good evening, and thank you for the invitation to present at this third annual Neuro-Oncology Symposium of the PASNO. I'm extremely delighted to participate in this meeting again, and I want to thank the organizing committee, particularly Professor Inam, for this invitation and the ability to participate again. Let me share my screen. So I'll be talking about what we have learned from clinical trials in neuro-oncology in the variety of trials that we have done and where we go from here. I'm Vinay Pudwali. I'm a professor and the chair of the Department of Neuro-Oncology at the MD Anderson Cancer Center. I also co-direct the Brain Tumor Center here in this institution. So let me start by talking a little bit about the challenges that we have faced in neuro-oncology and outline some of the questions we'll answer during this particular talk. So we could briefly overview the trials that we have been successful in. So that way we get an idea of how we were able to do something well. We have to also look at the trials that have failed despite what we thought was early promise. And in that case, we have to see where is the translational disconnect? Where did the preclinical studies not clearly tell us where the trial outcome would be? And there's also a clinical disconnect. Sometimes early studies do not tell us how the later studies will perform. And what can we do differently in this setting? This is an important question that we have to kind of grapple with to see how we can optimize our trials and sort of then get a sense of, are we there yet, or do we have more work to do? So one of the first trials that I want to talk about that has been highly successful was the landmark trial by Dr. Stoop and colleagues. As you're well aware, this is a practice-changing trial with improvement in overall survival, not just in the median survival, but also in landmark analysis at the 24 and subsequent months as well. What was important about this study? So the drug itself was found to cross the blood-brain barrier very efficiently. It was an alkylating agent that was a little different from previous alkylating agents. It showed early activity against brain tumors in preclinical models. It was orally available, easy enough to take, and there were probably less known than this large study, a previous study that Dr. Stoop had published in JCO several years prior to this paper, which showed in a phase 2 study that there was a similar improvement in survival and median survival as well as at 2 years and later. So lots of rationale that led up to the point of this larger study. The study design was very straightforward. And as you can see, that study not only held out in the time period when it was reported initially in 2005, later analysis of the same data of the patients showed that that benefit not only was important in the early phases, it held out later, showing this a sustained and very clear benefit in this population. So this is an example of where the preclinical, the translational, and the clinical worked really well in sync. And all of those data showed the same results towards the practice-changing results we see here. Along those same lines, MGMT promoter methylation has been recognized long as a factor in alkylator therapy efficacy. So for decades, that's been known, and that all came together in this part of the study by Dr. Hagee and colleagues in the same study that was published by Dr. Stoop. A subset of those patients were taken here. This was not a confirmatory study. This was a study that was exploratory in the sense that they were looking to see if MGMT methylation really made a difference. And of course, most of you are familiar with the results of a dramatic difference for patients with MGMT promoter methylation compared to those who are unmethylated in this population. So conclusions were drawn at that time that maybe unmethylated patients should not receive temozolomide because it is not predictive of that. But it is clear that there is a prognostic value to this, because if you look at this population, and let me show you these two areas here, the curve here. The early part of the curve hugs very closely. Methylated or unmethylated, there is not much of a difference. The latter part of the curve shows you that there is a separation, but they're both flat, as in these are long-term survivors in the unmethylated group doing as well as the methylated promoter group. So these two populations seem to have similar characteristics, whereas the major difference comes in the middle of the curve. So what was it about the methylated patients that they didn't do so well? And what is about the unmethylated patients that they did as well as the methylated patients? These are things that we don't fully understand yet. And when you look at the long-term results, you can see in the unmethylated group with the combination study that there were long-term survivors that went on to 6 years or more. And that's the important factor to say there is a subset of unmethylated patients that can benefit from this treatment as well. And hence, we cannot dismiss temozolomide in those patients. Again, these are things that we have systematically understood and we are able to glean from such successful studies. But then let's switch to this idea. So can dose intensification of temozolomide now improve outcome? That was the next question that was asked. And here you can see where dose intensive Temodar was given compared with the standard Temodar. Up to 12 cycles, please note, as opposed to the 6 cycles in the Stoop regimen. But the results showed that there was no difference. So if you intensify temozolomide, no difference in outcomes, whether it's overall survival or progression-free survival. And the thing that this leads to is to say that somehow we have managed to saturate the effect of temozolomide with the first dose schedule that was selected, which was mostly derived from preclinical studies for the convenience of dosing. And yet, dose intensification did not help. So we know in some tumors, dose intensification seems to help with outcome. Gliomas seem to be not one of those, at least with this kind of alkylating agent. However, there was a very important benefit from this study, even though it was negative. That was the MGMT promoter status value as a prognostic marker was established here, because you can see a clear difference between methylated and unmethylated patients. in overall survival and progression-free survival. So this is one important lesson. Maybe a primary assessment of the overall survival between these two arms was important, but didn't turn out to be valid in terms of a difference, but you still gained information because other questions were added on there that were valid and as well as powered to see that difference. So very important point of how trials may be constructed, but a negative trial can still give us a lot of information. That was true in this particular study as well, RTOG 0825, and the other European study, the Evaglio study, in which temozolomide plus placebo on one side was compared to temozolomide plus bevacizumab, an anti-angiogenic agent, both during radiation and after. Again, unfortunately, the results were negative. This is Dr. Gilbert and colleagues, just like the previous study. Interesting data on the progression-free survival, which did show a benefit, and again, the establishment of the MGMT promoter methylation, confirming that status as being important in these tumors. So trials have been negative, and in this case, you can say, why did this trial turn out to be negative? There was not a whole bunch of preclinical data that supported an idea of using anti-angiogenic treatment at the onset of the disease. So you could say these are patients who have resected tumors. The anti-angiogenic angiogenesis is not a big factor at that point. At recurrence, obviously, there is angiogenesis and enhancement, etc. At this point, you have a patient who's largely resected of the tumor. Was this the wrong population of patients to expect that benefit? However, the alternative argument was maybe we could prevent angiogenesis by keeping bevacizumab continuously through the course of this, so progression will be delayed. And in fact, we did see progression delay, but when the tumor grew back, the patient's outcome did not differ. So maybe such a strategy only can help with progression-free survival, but not with overall survival. So there were lessons learned, there were markers tested, and there was a question of whether there were subsets of patients that benefited from this, and that requires, again, information that we have. So these are negative studies, but they also provided a lot of information, and that's important to note. But there were many other studies that did not pass muster. For example, the enzastorin study that was enzastorin versus CCNU in recurrent GBM, there was minimal preclinical data for this particular target in GBM. Yes, it was expressed. There was some data to support that it may be a target, but there was not robust data. There's almost no phase 2 experience with this combination or the control arm comparison. And it was a monotherapy targeting one target in a very, very complex tumor. And the target was not very validated. So if you take all of these into consideration, there was a concern that this trial would not have worked anyway. But there was a jump from an early phase study to a phase 3 study, which then failed to show any benefit. So rushing in with single agents into this disease is not a good idea, is what we learned from something like this. Other approaches, here's modified diphtheria toxin conjugated with transferrin. This was terminated because of negative results in 2006. So there was some preclinical data, but it was not necessarily applicable to human studies, again, because of the complexity of the human disease. Was the target really valid enough to be utilized? The CED delivery, the convection enhanced delivery that was used here, did that really deliver the product, which was a fairly large product, into the tumor in sufficient quantities? I mean, these were not fully established before a large study was done, and all of those could have contributed to the failure of the study. Cediranib, this was a highly anticipated study, a pan-VEGFR inhibitor, the so-called REGAL study that Dr. Batchelor and team conducted. Well-designed study, doses were chosen, placebo-controlled, CCNU was the control arm, but unfortunately, again, did not show any difference, despite the fact that phase 2 study of the same kind actually showed benefit. So why didn't the phase 2 tell us what the phase 3 would do? So what is the gatekeeper function of the phase 2 study that didn't work here? So there was a slight change in the dosing that was used from the phase 2 to the phase 3. And the lesson that VEGF inhibition through bevacizumab, which showed progression-free survival, did not necessarily mean the same thing for VEGF receptor inhibitors. So the pathways look like, if you break it down into its components, that hitting the ligand is not the same as hitting the receptor. So again, lessons learned, but the phase 2 function in terms of maintaining the design of the phase 2, and whenever that is successful, carrying that on to the phase 3 in the same way, maybe one of the lessons that may have been learned here. The last trial I'll briefly talk about is the IL-13 linked Pseudomonas exotoxin study. Again, the IL-13 receptor expression in GBM was the basis for this. So if you injected the IL-13 with this toxin, that the IL-13 would bind to the receptor and kill the tumor cell through the toxin expression. But again, it was a CED-based delivery, and we still are not sure how well CED can deliver a large molecule such as this. And this trial also did not meet its interim efficacy endpoint, and hence it did not move forward. There were many other issues that may have been a problem here. Was the target expression of IL-13 receptor uniform across the tumor in the human being, not in the preclinical models? Was the distribution of the drug even across these things and catching all the tumor cells that need to be targeted? These were questions that may not have been fully addressed before the trial went in. So there are probably more preclinical work as well as small human trials that should have been done prior to entering into the large study. Immunotherapy has been a big promise, and we have really tried to see if we can get immunotherapy into brain tumors to get the same results that we saw in melanoma and lung cancer and other tumors of similar kinds. But it has been also, unfortunately, unsuccessful. So here's the Checkmate 143 trial that Dr. Reardon and team led in recurrent GBM. Again, no difference between Nivo versus bevacizumab. Again, the preclinical data on this in this particular setting was only building up, and the phase 2 experience was not as robust. The relevance of PD-L1, which was seen in lung cancer, was not the same in brain tumors. We learned along the way that that may not have been a relevant factor, and towards the end of the study, when the tissue was received, it was the same kind of thing. There was no clear correlation between the two. There were some other interesting results, though, from this study. We learned that baseline steroid use in unmethylated MGMT patients had actually a worse outcome than the control arm. And the best outcome was for patients who had the MGMT methylation and no baseline steroid use. So the interaction between steroid use and the methylated and unmethylated tumors became important in terms of the information gleaned from this. So even though this was an unsuccessful study, the team was really good in terms of meticulously looking at all the factors that might lead to success or failure. So that was a lesson learned, and they took that into the next study of newly diagnosed methylated MGMT GBM patients using this particular data, and then controlling the steroid use in this. The patients went into the Checkmate 548 study. But again, unfortunately, the trial had negative results during interim analysis. So this was a very reasonable rationale. There was information that was gathered from the recurrent study and applied to this, but clearly it looks like what we find in a recurrent setting might not be applicable in an upfront setting. There are some preclinical data. These are extremely difficult to model, but the highly immunosuppressive environment of the GBM, the fact that there are very few T cells in the tumor, so that the activation of this with a PD-1 inhibitor, even though it happens systemically, does not enter into the tumor. These may all have been factors that led to the failure. And that is leading to many combination approaches to see how we can overcome that, and whether increasing the T cell activation and entry into the tumor and decreasing the immunosuppressive environment within the tumor. These are things that we have learned from these larger phase 3 trials. Success can also come with patients, and the RTOG 9402 and 26951 EORTC studies showed that, where early analysis done here would have resulted in a negative call to say that the drugs do not work, the treatment was not beneficial. But the investigators persisted and then continued to follow those patients. And then later in the years, you can see this is a 7 to 8 year, 6 to 7 year analysis. This goes up to the 12 to 14 years. Clearly, with that patients, there was a separation of curves that showed the benefit of the treatment. So not making early calls in certain types of tumors, tumors that have better prognosis, like oligodendrogliomas. Same lesson learned with low-grade gliomas as well. This is 9802. Early on, there was not a clear difference. There's a question of whether there was benefit, but as the trial continued and matured, you could see the difference emerging. So not only is it important to look at trials in terms of analysis, it's also important to know when that analysis may be actually most important. So the persistence and in follow-up and structure of the trial, which allows capture of this information, was crucial in both of those types of tumors. So success here was not just the success of the agent, it was the success of the design and follow-up as well. So these are another aspect of the trial that we should be keeping in mind. We are all well aware that targeted therapies against gliomas, a large number of them which have been conducted, have failed uniformly across the board. Most of them, as you see, are single-agent trials. Many of them were combinations as well, but looks like the complexity of the tumor really defeats the approaches that we have taken in those areas. Anti-angiogenic strategies, which are thought to be really important, also have failed. So clearly, we don't understand those tumors in their full complexity, and targeted therapy looking at specific pathways in the tumor are not working. So that's the biggest lesson. Single pathway targeting is not a good strategy in this type of tumor. Immunotherapy has had a similar result. There are several trials that we had great promise in EGFRB3 vaccination, peptide vaccination, highly anticipated study, but unfortunately it did not pan out in the phase 3. ECVax had more promising results, and looks like there's more to be learned there, but clearly there are some selection criteria that need to be included there. So we cannot treat all patients with these kinds of strategies. We have to be very selective. Other trials have not succeeded, unfortunately. So immunotherapy is still under review, but so far we have not found that Achilles heel in the tumor to be able to get immunotherapy to work. What's the translational disconnect here? So this is important, and I don't know I have an answer for this. This is something that we have to, as a field, collectively think about. A great example of this is a very, very hard work done by Dr. Jan Zakaria and his team, who has a fantastic translational lab. He has animal models that he tests these tumors with. And here that team looked at veliparib, which is a PARP inhibitor that crosses the blood-brain barrier. So they had due diligence in terms of selecting the drug well. They tested in preclinical models, multiple models, in fact, showed the benefit of the combination of temozolomide and veliparib over the single agents. Did not stop at just one model, actually tested it across various spectrums, looked at resistant and sensitive models, etc. And then very carefully designed the study in which they had a seamless phase 2 to phase 3 design. Very important, again, to be able to stop a trial early if it didn't work so that it doesn't go into a large trial without clear idea of benefit. So that futility analysis was very important. So the sample size was collected, the primary endpoint for the phase 2 and phase 3 were determined, and the trial was launched. So this was done as well as any trial could be done, but in terms of taking lab findings to the clinic. Unfortunately, as most of you may be aware, this result was presented not too long ago at ASCO. And the two arms did not show any difference. Whether you had veliparib or placebo in combination with temozolomide, there was no difference in outcome. So the question is, what happened here? Everything was done right. So I think the answer does not lie in the efforts that were put in here, not in the amount of work that was done. Those were all done very well. What might have happened is something that I'll discuss in a few minutes, which is were those models predictive of what the outcome would have been. They may have informed biology, but were they predictive models for this disease? And that may be where the disconnect happens. So we do need robust preclinical or early clinical data for some of these things. Like, is the model used representative of the paradigm tested? We are still struggling with this. We do not have models that represent the human experience with these agents yet. But there are other questions we can answer in these models, like, does the drug cross the blood-brain barrier? Or if it's a non-tumor target, does it engage that target? Is that target expressed in the majority of tumor cells? If it's a tumor-targeted therapy, or if it's an immune or microenvironmental target, is it actually attaching or engaging those cells? Does it induce the target inhibition because you're trying to do something? It may be inhibition or activation, depending on whether it's tumor or immune systems, but is it doing that across the cells that we are targeting? And if it is actually activated, does it cause a biological effect? Is it killing cells? Is it inhibiting cells? Is it causing a cell cycle arrest? All of those kinds of questions related to the drug itself. And finally, the fact that the biological effect happens does not always mean it can change outcome. It has to be a widespread biological effect. And the question is, does that then connect? So getting this information as much as possible in the preclinical setting is really, I think, the value of the preclinical studies. And then nuancing that to see, are there subsets of patients that may be best served by this? We're trying to do this in MD Anderson through what we call a GBM moonshot program, which has a discovery element where we take tumors and then try to understand what the tumor basic discovery units are like, what are the targets, what are the analysis that we could do. Then we try to move that into the translational setting of developing drugs or targets that can be tested in this model, and then finally moving that into the clinic. And I want to briefly talk to you about Accelerate, which is one of the platforms that I mentioned there. And this is the screening model here. We test a number of models, but to me, none of these models are predictive, as I mentioned. So we have developed an ex vivo human tissue model where we take human tumor and then make slices out of that and then try to run that for testing of drugs. We want to collect all this data, do a review, and then make a go, no-go decision. And if the study is promising enough, then go into not into a phase 2 or phase 3 trial or larger trials, but do an early phase trial, small number of patients. Test in these patients whether all of these paradigms exist. So this is an approach that we are taking to try to see in this smaller number of patients whether we can sync the preclinical data with the early clinical data before we go into the next step of the treatment. We also are conscious that these treatments may develop resistance mechanisms in the tumor, and we have to study those as well. Here's a brief overview of the organotypic slice culture model with human tissue. The tissue comes from the OR, undergoes slicing with the vibratome, which does not cut across, it kind of lifts the cells off, and we are able to maintain these viable tissue slices, check their viability, and then test drugs in these human tissue slices. So this is human tissue, and so we hope that the findings here are more relevant to the human than the other models. So understanding these resistance mechanisms that may come from this is very important, and we have multiple resistance mechanisms to almost every type of treatment that we have tried, including biological agents and immunotherapy, as I mentioned. We have different ways of testing that, whether it's induced resistance by generating resistant lines or CRISPR-based synthetic lethality, whereby we test by knocking out various genes in the system to see which one is synergizing to induce synthetic lethality. So through this, we try to get combination ideas that we can then test in the clinic. Now, I want to talk a little bit about a different strategy that's happening in the field, which is companies, pharmaceutical companies are now going into what are disease-agnostic targeted therapies, which means it doesn't matter which disease it is, if it has a certain alteration, so here in this case, BRAF V600E mutation, positive cancers of any kind, does not matter which the tissue of origin is, but all those patients to the study and then ask for approval for the entire spectrum. Here, there's a grade 1 or grade 2 glioma or the grade 3 or grade 4 arms in this large study. And that was analyzed, reported by Dr. Wen. And you can see here that there were several patients who continued on this study in the high-grade glioma as well as in the low-grade glioma category, suggesting that there was benefit in a subset of these patients. And in looking at these results, clearly there is a population that you can identify. But when the entire study received approval for BRAF V600E cancers, we are now able to access the drug through the FDA approval in the United States for the glioma population, which has this alteration as well. We're going away from doing glioma studies to large-scale studies that then, based on a mutation, that then give us access to the drug. And you're all aware that we have gone through a variety of classifications and discovery of various types of and subtypes of glioblastoma, as an example. And that has resulted now in a variety of subtypes. And we can no longer think of glioblastoma as a single disease. We have to begin to think of this as BRAF mutant glioblastoma. So we're thinking of methylated and unmethylated. We're thinking about this from an immune status. We're thinking about this in GSIMP. So a variety of methylation profiling status. So these are the ways that we are changing our thinking of glioblastoma. So from a treatment perspective, to do trials that say we'll put patients with glioblastoma on a trial may not be sustainable anymore. We may have to break it down into these subtypes and then do trials in each of those subtypes. So this is a reflection of the molecular heterogeneity of brain tumors, and I come back to this. Each time we do a trial, this is what we are faced with. We are faced with the heterogeneity of the tumor. We are not treating just one type of tumor. There's a variety of tumors, even though they are called by the same name, and it's not surprising that we don't get a response across the board. That is also reflected in the methylation profiling, which even changes the diagnosis from initial to the final, for things like pilocytic astrocytomas becoming glioblastomas based on methylation profiling. These are profound changes in our understanding of the tumor. We have to be careful about what kind of patients we are putting in the trial. Otherwise, we're putting non-uniform patients that end up with disparate results that we have difficulty in interpreting. So here's just a summary of the variety of things that we face, whether it's stem cells or an immunosuppressive environment or the blood-brain barrier and the pharmacology of the drug, or particularly tumor heterogeneity. These are, I think, the areas that we need to be tackling now. And as you know, much research is going into that. And I think in each of these areas, as we get breakthroughs, we'll begin to see that, that advance coming in that subtype. I briefly mentioned the BRAF V600E mutant glioma approval with dabrafenib and trametinib in the United States, but that's not the only treatment that has been approved in a disease-agnostic way. We have NTRK fusion tumors of any kind, so gliomas are among them, and larotrectinib and entrectinib can now be prescribed for these patients with gliomas. If you have microsatellite instability or high or tumor mutation burden high, pembralism has been approved for any disease, any of the cancers that were tried that have that finding. Similarly, defective mismatch repair gene. If you have that in one of the gliomas, then dostarlimab is one of the things that can be used here. So we may see more and more of these coming where disease-agnostic approvals will allow us to treat subsets of glioma patients, even if there is not a trial, a large trial of glioblastoma or glioma patients for that particular drug. And there may be more subsets like this coming in, and we may need to find those subsets in order to identify the responders to targeted therapy. So you're all familiar with this progression from the old days where we were trying to add chemotherapy, seeing very little difference, to the EORTC trial, NCIC trial, which showed the benefit of temozolomide. And also the TTF trial, which has now shown benefit in addition to temozolomide, which has now pushed the curve even further to the right. And so these are all advances. And do we go in this direction of incremental benefit, or will we break down the tumor and then have unmethylated and methylated, and we are looking at BRAF V600E or not, and that sort of approach. So this is what we have to, I think, consider going forward. So how do we address the translational disconnect? Again, as I mentioned, current preclinical models are not predictive, and we need predictive models, and this should be a huge effort in our field, trying to see how to develop those complex predictive models. And that may need to be human tissue based and not necessarily animal based. And the preclinical studies should also include resistance assessment, so we can identify combination strategies early rather than go the single agent route all the way to late studies and then find that it doesn't work. And again, human tissue-based studies, clinical trials with small numbers of patients, collect the tissue, find out what the drug did, understand the biology and the alterations that I mentioned early on before we move into the larger clinical trials such as phase 2 or phase 3. Then using advanced techniques like single cell sequencing or spatial analysis of both the tumor as well as the microenvironment may be important to understand what the tumor heterogeneity really means, and then modeling the treatments after that. For large studies with small expected benefits, like we saw with the or late expected benefits, you have to wait for results to mature. We learned that from the low-grade and the anaplastic glioma trials. Window of opportunity trials, drug before surgery, and then test to see what happens in the tissue may be very important. The idea of sampling the progressive enhancement. So put a patient on a study, the patient progresses at some point. We don't know why the patient progressed. We don't always go in to take the tumor out to see what is the change that happened from the baseline to the progression. That paradigm may need to be incorporated into our trials. First reason to do that would be to confirm that these are tumor progressions. There are pseudo progressions and other issues that happen. So confirming tumor progression is the clinical need for that. And through that, we can maybe also identify resistance mechanisms. We are in the field now embarking into multiple biopsy studies that is along the course of the disease in the same patient, trying to do biopsies at different stages of the treatment in the individual patient. Very challenging because it's very expensive. It's not often approved by regulatory agencies, but this kind of a study has been done in by the Japanese teams and have shown benefit. Similar study designs are being explored now in the United States as well. Deep dives into the tissue and as well as liquid biopsy specimens, and I should add imaging here as well to identify potential signatures that can pick the patients better, subtypes of patients. Improve patient selections for trial entry, again, through tissue-based data. So we sub-select the patient in terms of their subtypes rather than put all patients into a trial and see what happens. And through this, new trial designs may be necessary. I talked about the multiple sampling as an example, but Agile is a very good example of a global study, which is looking at a control arm that continuously runs in the background while multiple treatment arms can be tested and compared against the control arm that may lead to regulatory approval in a faster basis. That design also allows for subtype selection for target-based, target-based specific therapy. So it's a wonderful design led by Dr. Closey and team. So that is another way to approach the complexity here. And finally, I think we need to be focused on combination therapies to overcome resistant populations. With that, I briefly want to introduce Dr. Fred Lang, who's a co-leader in the Brain and Spine Tumor Center, Chair of Neurosurgery here, and Dr. Juan Fuyo Margareto, who's the Director of our Experimental Neuro-Oncology programs. Our team has been working very hard to tackle some of these problems. We don't have the answers, and we are part of a large team of people across the country and across the world that are trying to address this, and I think collaboration will be very important as well. Just want to also show you the Brain Spine Center where our team works. And this is where our medical center is. This is the MD Anderson campus that you see in the middle, and it sits in the middle of a large Texas medical center that is in Houston. And you can see our downtown here, and our medical center is almost as big as the downtown. With that, thank you very much, and wish you a very successful symposium. And again, congratulations to the organizers, and thank you very much for the invitation.
Thank you, Dr. Puduvali. I think that was a very nice, comprehensive overview of all the major trials that have been performed, especially in the last 2 decades, but also several insights as to the way forward. So I think we'll have some discussion at the end of all the talks. So it's my great pleasure to introduce to you the next speaker, Dr. Patrick Quinn, who is the Chief of Neuro-Oncology at the Dana-Farber Cancer Center in Boston, and also is a key opinion leader in neuro-oncology, having led and participated in several clinical trials in neuro-oncology. He's live, I think, Dr. Wen. Good morning, and thanks very much.
I think I have a recorded talk.
You have a recorded talk as well.
Yeah.
So can we play Dr. Wen's talk, please?
I'm Patrick Wen from Dana-Farber Cancer Institute, and it's a real pleasure and honor for me to be here at this wonderful symposium. I want to thank Dr. Enam and the organizers for the very kind invitation. These are my disclosures. It's clear that we need reliable, predictive, easy-to-use response criteria and endpoints in the clinical trials in neuro-oncology to determine the efficacy of novel therapies. I'm going to talk initially about clinical trial endpoints. I'll touch on the Renal criteria for gliomas, including Renal 2.0. And then at the end, I'll touch on the Renal criteria and endpoints for brain metastases. Some of what I will talk about are summarized in these 2 reviews, and I refer you to them for more detail. What are the optimal endpoints in neuro-oncology? The standard ones are survival, response, progression-free survival, and progression-free survival at a specified time point, such as 6-month progression-free survival. But there's also interest in other endpoints, such as clinical outcome assessments, neurologic function, seizures, and corticosteroid use. If you look at the approvals by the FDA in the US, most of the approvals have been based on overall survival, but there have been some approvals for durable responses, including the most recent approval for dabrafenib and trametinib for BRAF V600E mutated solid tumors, including gliomas. Overall survival is the time from randomization until death, and its strengths are that it's unambiguous, it's easily quantified, and not subject to investigator interpretation. But it has limitations, including the requirement for randomized trials. This in turn means large sample sizes and long follow-up periods. And the crossover from control to the experimental arm can dilute the overall effect, such as has been the case in the trials with bevacizumab or Avastin. Progression-free survival is the time from randomization to progressive disease or death. The strengths are that it requires shorter follow-up period than for overall survival. It takes into account stable disease. The treatment effect is not obscured by subsequent treatment, and there are extensive historic benchmarks. But there's potential for bias, and so this endpoint also requires randomized trials. Progression can be difficult to reliably assess in some tumors and therapies where pseudoprogression is common, and this is the case for glioblastoma. It requires consistent use of assessment at baseline and at regular intervals. And so although it's very tempting to use progression-free survival in glioblastoma studies, this is in general not a reliable endpoint. Objective response rate is a percentage with partial or complete response. The strengths of that tumor shrinkage can be that it is unequivocally attributed to treatment in the absence of confounding factors. It does not require a randomized trial, and the FDA will grant accelerated approval based on significant and durable responses in single-arm studies. The limitation is that assessment of response duration is required, and the assessment can be difficult in some diseases and with specific treatments, particularly in the case of glioblastomas with drugs that affect vascular permeability, such as bevacizumab, which can cause the phenomenon of pseudo response. An example of a drug producing a very high response rate is crizotinib in ALK fusion non-small cell lung cancer. And in the phase 1, there was a significant response rate leading to accelerated approval of this drug very early on in development. However, in neuro-oncology, there's a problem of pseudo response where within a day, the reduced vascular permeability can make the scans look good when in fact there's really no real change in tumor size. This has confounded the interpretation of response in neuro-oncology, especially for glioblastomas. Ben Ellingson and a group of us have been working to try to define what is an appropriate response rate for glioblastoma. In looking at all clinical trials for glioblastoma, the average is well below 10%, and it's 5% for Temazolamide. An exception is dabrafenib and trametinib for BRAF V600E mutated glioblastomas that contributed to the recent approval in the US. And the response rate in glioblastoma in that study was 32%. For most modalities, there is a correlation between the response rate and the overall survival. This, however, is not true for anti-angiogenic therapies. But we propose that for non-anti-angiogenic therapies, a response rate of 25% that's durable is a reasonable threshold for considering approval. And we're hoping that the FDA will agree with this. The recent approval for dabrafenib and trametinib for BRAF V600E mutated tumors, as I mentioned, was 32% and would meet this threshold. And then the final outcome criteria are clinical outcome assessments. This measures improvement in patient symptoms or function. The strengths are that it captures the patient's perspective and is a direct measure of clinical benefit. The limitations, however, is that it needs validated patient-reported outcome instruments. There's a potential for bias requiring blinded randomized trials, and there's often missing data, which often limits the interpretation of these studies. I'm going to now switch and talk briefly about the Renal criteria and Renal 2.0. In 1990, the Mcdonald Criteria was published to determine response in neuro-oncology, and it used the maximal cross-sectional area of contrast-enhancing tumor together with neurologic function and steroid dose. The limitations were that it measures only the enhancing component, does not address non-enhancing tumor, and does not address pseudoprogression, and with anti-angiogenic therapies, pseudo-response, and non-enhancing tumor progression. Because of this, the Renal criteria was published in 2010, and it tried to address the issues of pseudoprogression following radiochemotherapy and the issues of pseudo-response with anti-angiogenic therapies, and also non-enhancing tumor progression with anti-angiogenic therapies. As with the Mcdonald criteria, it uses two-dimensional measurements, the product of the maximal cross-sectional area of enhancing diameter. But in addition to measuring enhancing disease, it also takes into account non-enhancing tumor areas. The response has to be confirmed by a scan at least 4 weeks apart. And as with Mcdonald criteria, it takes into account steroid dose and clinical status. Because of the issues of pseudoprogression in the first 3 months after radiochemotherapy, increased contrast enhancement during this period cannot be taken to be progression unless the enhancing lesions are outside the radiation field or if there is pathologic confirmation of tumor progression. With the Renal criteria, non-enhancing disease progression is also taken into account, although this is often difficult to evaluate. An important aspect of the Renal criteria is that it allows for retrospective attribution when the changes are equivocal. If you have a patient who has possible progression, if it's clinically safe, and you're not entirely sure, you can keep them on study and repeat the scan. And if this confirms progression, then you backdate the time of progression to when it was first suspected. And it's really important to remember to backdate. After the Renal criteria was published, there was effort to develop consensus standardized brain tumor imaging protocols so that there's less variability in the patients who receive imaging studies, both at the same institution and between institutions. And this hopefully will improve the reliability of response assessment. With the development of immunotherapy, there was concern that these modalities can also cause pseudoprogression. Here is a patient who received an adenovirus that showed clear increase in the tumor that improved over time. To address this issue, the Renal criteria was developed. The basis of this criteria is that within the first 6 months of treatment, if the scans are worse and the patient is stable, you can keep them on study and you can repeat the scan over the next 3 months to determine if there's true progression before taking the patient off study. Unfortunately, with the first generation of immunotherapies with checkpoint inhibitors, the rate of pseudoprogression is incredibly low, only 2.5%. So most of the time, any worsening is true progression. The modified Renal criteria was also developed to address the issue of pseudoprogression, and this differed from the Renal criteria in 2 ways. The post-radiation MRI was used as the baseline, not the post-surgical MRI, and all patients had to have the progression confirmed by another scan before they could be taken off study. In addition, with all these criteria, clinical deterioration can determine progression. But when we published the Renal criteria, we did not have a good measure of clinical deterioration. So we suggested using a change in Karnofsky performance status. But there are efforts underway to look at neurologic assessment in Neuro-Oncology scale. This is a simple tool to look at neurologic function, and if it is validated, it may be a useful addition to the criteria. And then there is also interest in clinical outcome assessments. For low-grade gliomas, the criteria is very similar to high-grade glioma, except you look at flare signal And there is also a minor response category. But for low-grade gliomas, there are other endpoints that may potentially be useful, including neurocognitive function, symptoms, seizures, or the change in growth rate trajectory, as well as other measures listed here. Over time, it became clear that the original Renal criteria had limitations, and there was confusion about whether to use the original Renal criteria or the modified Renal criteria or the IRANO criteria. And so we've been working to update the Renal criteria, but this time based on data rather than just consensus recommendation. And the hope is to improve the reliability and reproducibility of the response criteria and increase the confidence regarding the results of clinical trial. Led by my colleague Gilbert Youssef, we looked at 526 newly diagnosed glioblastoma patients and compared the Renal criteria with IRANO and modified RANO, and really found that there was no significant difference. The one possible exception is a slight improvement in the use of the post-radiation MRI scan as baseline. And so in the new criteria, we will plan to suggest using the post-radiation MRI as the baseline rather than the post-surgical MRI. We will recommend confirmation of progression in the first 3 months after radiation therapy, but after that period, there's really no real benefit in confirmation scans, and we would follow the standard Renal criteria. For recurrent glioblastoma, we looked at 580 patients and compared the different criteria. And again, there was really no difference. And so we suggest just using the Renal criteria for recurrent glioblastomas. In evaluating the IRANO criteria, this really did not add very much. And the proposal is just to have a single Renal criteria for all therapies and not a separate one for immunotherapies. We will continue to use two-dimensional measurements, although there will be language that allows the use of volumetric measurements if the resources are available. Non-enhancing tumor progression did not really appear to add very much to the response assessment, and this will be dropped for most therapies, with the possible exception of anti-angiogenic therapies. With the new WHO criteria, there is now more mixture of the contrast enhancement in different tumor types. And the plan is to have a single round of criteria for both high-grade and low-grade gliomas, and not to have separate criteria. For glioblastomas, you would still measure the contrast enhancing disease. For grade 2 tumors, you would measure the non-contrast enhancing disease. But for some tumors where there are both enhancing and non-enhancing components, you would measure both components. And a response would occur if there's a 50% decrease in either the contrast enhancing or non-contrast enhancing components, and stability in the other component, and progression if there's a 25% in either component. Keep the minor response criteria. Ultimately, we would like to have this process automated, and hopefully this will be something that will be reachable in the near future. And then finally, just want to mention very briefly brain metastases. There's tremendous interest in trials for brain metastases, and responses have been seen in both targeted therapies and immunotherapies. The problem with brain metastases studies is that they often enroll heterogeneous populations. There are many different endpoints used. There are different definitions of the same endpoint, such as response. There are different methods of assessment, and what endpoint is appropriate in what circumstances can be a challenge. And when is it appropriate to focus on the CNS, and how to factor in systemic disease status. In 2015, we proposed the Renal criteria for brain metastases. This is consistent with RECIST and uses one-dimensional measurement, as we could not justify routine use of volumetric analysis given the cost and complexity. Measurable disease is defined as tumors with minimum size of 10 millimeters diameter, although we acknowledge that many trials enroll patients with smaller tumors, and there is allowance for this in the criteria. As with rhesus, partial response is 30% decrease in the sum of the longest diameter relative to baseline, and progression is a 20% increase in the longest diameter compared to baseline. And it also takes into account clinical status and steroid use. The main difference with the Renal criteria is that it assesses the CNS as a different compartment compared to rhesus. And so studies can report the CNS response rate, for instance, for radiosurgery trials. They can also report a non-CNS response rate. The progression-free survival should be bicompartmental, especially for systemic disease. The CNS PFS and the non-CNS PFS can also be reported separately. So this is a very quick run-through of clinical trial endpoints and response assessment. I want to acknowledge the people who contributed to Renal 2.0, and thank you so much for inviting me to this wonderful meeting. Thank you very much.
Thank you, Dr. Wen. Very nice, comprehensive again. Would you be with us for the end of the discussion, Patrick, or should we ask?
I'll stay until the end if there are questions.
Thank you so much. So we move on to the next speaker is Vijay Patil. Dr. Patil is a professor of medical oncology at the Tata Memorial Center in Mumbai, and I would like to hear from him how you actually do it in the lower middle income countries. And Vijay has a very large experience, not only in conducting neuro-oncology trials, but also in other solid cancers, notably head and neck and lung cancer, which has made to premier platform presentations in ASCO, as well as key publications in major international journals. Dr. Patil, please go ahead.
Yeah, thank you, sir. Thank you, the organizers, for this opportunity. And when I got this topic, I was a bit confused at what should be I speaking on. So I decided that let me speak about how we actually did the trials. And the assumption goes that the situation which is there in India at Tata would be very similar to the situation would there be in Pakistan at Aga Khan University. So I thought that we'll share for what we did and what were the things where we failed and what were the things which we did actually led to the things, the studies going better. So let's start from the concept. And now it's very important that we have this difference very clear, that when you're going to do an investigative study, or what we could call as an academic study, the investigator has a dual responsibility. He not only is a researcher, but is also a regulator. And for all practical purposes, and this can be verified by Dr. Tejpal and Dr. Jalali also, they have done PI-initiated studies. The PI does everything. He writes the protocol, he puts the paper to the ethics, he runs the study, he does the data collection, he does the analysis, he writes the first draft, and he is the person who communicates with the journal also. This is different from the pharma-initiated study, where the protocol is developed by the sponsor with some key opinion leaders, and then it comes to your institute. So in an investigative study, the PI is responsible for everything, and he's both a researcher and a regulator. Now it's important that we have this investigative initiated studies. A lot of time you would see that multiple questions which we in oncology we have are critical and which we think as academicians are important. The pharmaceutical industries, or for that matter, even the radiation machine industries, or for the surgical instrument industries, won't be interested in answering these questions. For example, today in lung cancer, there are multiple immunotherapy options, and the cost varies in between them in few lakhs in Indian rupees. But we don't have any idea which among them is better. A simple question which actually is running a study in Tata is, oligodendroglioma grade 2 or grade 3, or an astrocytoma grade 2, grade 3. Whether we should use PCV or whether we should use TMZ. Or a question like, what are the different fractionation regimens for RT? These are questions which are very important academically, but are not that key to the industry. And this is where the academic contributions come into play. Second thing is, what we realize in Tata is that most of the drugs which are there are at the start quite costly and are not affordable by most of our population. Like, for example, we did an analysis for immunotherapy accessibility in our country, and it came that in 15,000 patients, only 2.8% of our patients could afford them. So can we do something about the doses here? So we work a lot on metronomic and low dose scheduling, and I'll be showing you some of our work also. So this is another important concept which no one is working, but it makes things easy because these drugs are available, and whatever solution you give, the important is that this can be applicable in your own country from next day itself. Similarly, we work a bit on repurposing also. We have repurposed mebendazole for gliomas. And again, the good thing is that these drugs have lost the patent. They are readily available and they can be used. You could work also on innovative schedules and deliveries. Sometimes some vials most of the times are made with the Western population in reference, with their weights within 80s and 90 kgs. Most of our patients' weights are in between 40 to 50 kgs. So questions like whether a vial which has got open, can it be used multiple times? It's a very good question to answer. A lot of supportive care studies, like what is the value of addition of early palliative care? What is the value of addition of physiotherapy? Patients who are undergoing chemotherapy have chemotherapy-induced nausea and vomiting. Post-operative patients with abdominal chest surgeries have pain. Can we have some distraction strategies? Mobile games playing, can they lead to a decrease in pain and decrease in vomiting? Are good questions to answer. Also, the one good thing is to look at cost-effective strategies. There are other studies which can be done as an academician, which are like screening studies, administrative studies, and this is something which I am interested in. Do every patient, see, we have Tata Memorial Hospital, but 50 to 60% of patients in Tata who come from outside the state of Maharashtra, and the state of Maharashtra boundary around Bombay is around 300 to 350 kilometers in each direction. So they have to travel 400 plus kilometers. Do they actually need to come? Can we do a video follow-up for these patients? Can we do a video follow-up for patients who are on Temazolamide? These are some of the questions which can easily be answered. In fact, one of the questions we have already answered. Genomic studies and studies for predicting adverse events are good things to start for the startups. So it's not important that you need to have fancy drugs, you need to have fancy labs. What the point I was making is that there are multiple things in limited resources, multiple concepts on which you can work in a low and middle income country. And let me give you some pearls which me and my colleagues at both at head and neck and neuro DMG and thoracic DMG have learned through me. For important thing is feasibility, and feasibility is important. You may have a sample size of 1,000 patients. Are you going to get those patients? At India, and I'm very sure at Pakistan, we would having a very high clinical load. We would be seeing multiple patients in the OPD. We always feel that all these patients can be recruited on the study. And this was the rule given to my mentor, to me, Dr. Gary Clark, that if you see 100 patients, divide that number by 4. That is the number of patients you might be able to recruit in the study. So always use this formula to see how many patients you could use. Am I making methodology too strong? Sometimes we get impressed with studies which are coming from high-income countries. Understand that they have free academic, they have OPDs for 1 or 2 days, and the rest 2 or 3 days are for doing studies. In most of the low and middle income countries, you will have to finish your OPDs, you will have to finish your academic work, and then in 1 or 2 hours or in the evening, you will have to do your research. So don't make methodology too stringent. Try to keep methodology as possible as what is done in your routine practice. Don't try to add layers and layers of extra visits to the patient or investigation to the patients. Choose your friends carefully. not all colleagues will be cooperative. I was lucky to get cooperative colleagues like Dr. Jalali and Dr. Tejpal. Everyone is not cooperative. So you choose your colleagues which are going to cooperate with you. And the golden question, if you are going to go have some intervention which would require cost, have an select an idea from where would you be getting the funding, because you may do everything. You may write a good protocol, you might get an ethics clearance, but if you don't get the funding, you cannot do it. Saying all this, Pico, that is which population you will do, intervention which you're going to do, what is your control and outcome remains important. For youngsters, if this is your first study, start with a simple question or an intervention. Quite commonly, I have been seen now, I'm in Tata for last 10 to 12 years, and I have an academic career now spanning now 15 to 16 years. I see that the youngsters have an idea that the first study is going to be a blockbuster hit study, which is going to change the things across. So it's mistake in the first study is a norm. Understand that you're going to make a mistake. You're testing your waters with your colleagues. You're testing your water with your ethics. You're testing your own capabilities in an institute when you're doing your first study. It's important that you do a simple question, do a simple study, which will give you the confidence that you can do it. You can very well do a good study also if you have a very good mentor backing. Now, when you're selecting a situation, select a situation which is ample and common. Do not go for uncommon situation, or do not go for uncommon tumors also. It becomes difficult to recruit these patients. Always remember, this is a habit, that today I may do some work on febrile neutropenia. Tomorrow I may go do some work on lung cancer. Day after tomorrow I'm doing a work on anemia. It's difficult to create a niche area for yourself if you go berry picking around and doing works in different parts of oncology. It's better that you focus an area where you are comfortable with, which is of your interest, and keep on working on your work. And I'll give an example. Like if your interest is glioma or it's recurrent gliomas, and you start with a retrospective analysis to see what is the outcomes with CCNU, all for that in your population. Add on, consider doing a prospective study with some agent for repurposing or with a new agent. You do that. If it's successful, go for the phase 3 in that. This is the same way you keep in a peculiar area, you keep drawing forward rather than going broad ways in different areas, because that actually takes you nowhere, neither it takes science anywhere. It's always important that you select your collaborators carefully. You should have a good relationship with them, and your collaborator should have a good track record. And it's important, especially if your collaborators are elder to you, or even if they're junior to you, you convey to them what is exactly what you're looking from them. Important, look at the workload. Quite a few times, successful collaborators or good collaborators are heavily loaded, especially in low and middle income countries. You will see that there are only few scientists, few basic laboratories who are doing good work. It's difficult to get your translation work done in such labs. So you keep your expectation down in this situation. Well, how do you go about selection of methodology? Initially, it's better to you go with a simple design. You would be testing your statistician also along with this. Getting good statistician in low and middle income country is difficult. Many times they are good theoretically, but they don't understand medical language. They don't understand sample size calculation. They don't understand the way we do analysis. So it's better that you have some knowledge of statistics so that you can convey to them in the language they understand. Simple interventions. Better to do standard arm comparisons for starters. Use a simple endpoint which is easily measured. And again, I would warn this, go for a simple follow-up, which is the standard in your institute. Do not go for a stringent study. Now, once you have started the study, and if a study is ongoing, do a few patients yourself. Do not delegate it to your co-investigators. Be slow in the initial patients. Select your patient judiciously. You may be a bit stringent on the inclusion criteria at the start. Somehow I have seen in my experience that in the initial patients, you do develop side effects. So be prepared. In a heavy OPD, it's difficult to remember the inclusion and exclusion criteria. So your protocol should be printed with you in your OPD. It should be sticked on the walls, and you should have it in the mobile for quick reference so that you can easily identify a patient if it is to be there. Make an Excel sheet, sit with a coordinator so that you could track your patients. You should have a calendar which will tell you that these 5 patients are coming for this visit, these 3 patients are coming for this visit, and this patient. This helps you to decrease your loss to follow-up and call up a patient to see if it doesn't come up on a follow-up. And above all, you need to relax and enjoy. This is going to be an ongoing daily, what you could say, something which you're going to do a daily chorus. So you need to enjoy these things. Look for SAEs, deviation and violation, and report them on time. And most important thing, do not bother what non-researchers are saying. You are going to get criticized, especially if you're doing in low and middle income countries, because whenever you do some amount of research, you would be compromising on your service part and your education part, and you would get criticized for that. So don't bother, continue what you are doing. Now, these are the mistakes which I did. Don't be very over ambitious in your first study. Do not go fast. Do not do fast recruitment. It becomes difficult to follow up those patients. Do not underestimate your structure in your OPD. If you do train your coordinators well, they will do very good work with you. Do not forget to track your patients. There is no fun in including the patients, but if there is a high loss to follow-up rate. Check the study progress after every 10 patients and at regular intervals. This helps you to keep track of things what are happening. I'll say some words about funding because this is where it gets complicated, especially for early researchers, because they don't get funding. Wherever you go, they keep asking you, what have you done? What have you done? How many projects have you completed? And it is difficult to get the funding. Just to give an idea, this is the amount of funding I could have be able to get from 2015 to 2021. It comes into around few crores in Indian rupees. But you could see that there are multiple places I have tried, not only intramural, extramural. What you must understand is the institute, if it has grants, you need to tap those grants. Government agencies, this is what is there in India. I'm not sure about what is there in Pakistan, but you need to tap those grants. Remember, pharma companies have a CSR fund, and if you channelize them properly, they will come. They also come up with pharma companies do come with competition if you're going to use their drug incorporate into the protocol. And these competitions are there every year, so it's better to if you could participate in this competitions. Look at your national societies if they are providing some funds. Look at non-government organizations. We have been able to convince a few non-government organizations in last 2-3 years, not before that okay, research is important and it improves and benefits a lot more patients than providing drugs for 10 patients or 20 patients. If you do good research, it actually impacts a lot more patients, and quite a few of them do listen. Patient donations are also good ideas. We have just finished a study in which the patient actually donated the funding for the study, and it was around 1 crore in Indian rupees. So getting such motivated patients, and Dr. Jalali, I learned this from Dr. Jalali, in which patient families, when counseled well, even if the patient has passed away, they are looking at the service they receive. They are ready to do donations for specific studies in specific areas, and you need to guide them to where this funding can be helped. You require a lot of motivation to be done. Understand that investigators in low and middle income countries have far different problems from high income countries. So it's important that institutes provide some insurance to them, like providing initial seed fundings, allowing 2 standard arms in the protocols, allowing pragmatic trials, and some research staff provision needs to be made by the institute to help the investigators. And this can be in the form of developing a common CRS, keeping common statisticians who can help them, keeping a pool of coordinators who can keep rotating so that people can be helped out in their research. I'll give you some examples of using this, many of these principles, what we have been able to do. This is a New England Journal publication which came from Tata Memorial Hospital. It's talked about doing elective versus therapeutic neck dissection in node-negative head and neck cancer. It was a seminal paper, and both of these arms were standard. It took some 10 to 12 years of recruitment, but this was possible before the IEC allowed 2 standard arms to be used, so no financial implications were there on the study design. Another example of a study, this is done by our current director, Dr. Badvisa, in which you looked at if patient had an oligometastatic breast cancer, whether doing surgery to the breast would improve outcomes. Again, both arms were taken as a standard, and this rule of the ethics actually allowed the study to be finished in no time. Another example from head and neck DMG done by my senior colleague Dr. Sarbani Lashkar, in which different fractionations along with chemoradiation were compared. Again, all three arms were taken as standard by the IC, and support was provided by the institute in this, and hence this study was completed and subsequently presented as an oral presentation. Another example from head and neck DMG. We all know in head and neck cancer, cisplatin 1 weekly or 3 weekly is a big question. And this was done by my colleague, Dr. Narona. And again, this was an ASCO podium presentation in 2017. So I thought that I would talk only about Tata. All India Institute of Medical Science, New Delhi has done some great work. This is another example of that best supportive care versus chemotherapy. Both arms were taken as standard by the ethics committee. This was presented by Dr. Atul Sharma. Actually was the thesis of Dr. Amit Dawari, who is now a medical oncologist in Kolkata. The concert study, an ASCO presentation this year, again a weekly versus 3 weekly question by Dr. Atul Sharma. Both arms were taken as standard not only in AIIMS, but another 6 centers across India. Another study from our group, and this is an example of developing a low-cost therapy, a low-cost metronomic, which was actually a $5 therapy against around the cost of that time chemotherapy when this study was done, which actually brought the cost by around 1/10 of the cost of chemotherapy here. Completely oral therapy, because we saw that our head and neck cancer patients mainly are daily wagers and couldn't come to the hospital even for taking those IV chemotherapy cycles. So something like an oral therapy did well to them, and we did prove that this was as good as IV chemotherapy. This is an example of an ongoing study called TOP, in which this is what we are doing. We are comparing PCV versus Temazolamide. I'm happy to say that we have nearly finished 48% of recruitment for this study. And in another 4 to 5 years, I think more before that itself, we should, in 3 years, we should be finishing this study. I have to wait a bit more for the results to. It's important that when you do this kind of studies, or especially on low cost, it's or repurposing, we have developed models to identify adequate doses of these drugs. And for those models, you require to have good statisticians. I was lucky enough to have collaborated with Dr. Atunu Bhattacharjee, and all our metronomic work has been done with doing the biological work for finding the optimal biological dose of this metronomic chemotherapies. Phase 1 and phase 2 can also be done in repurposing and metronomic. This is an example of a phase 1 and phase 2 study in which we actually found out for oral therapy, how could we improve upon this oral therapy? And the concept of metronomic, the concept is that the dose of metronomic which will be effective is 1/10 of the standard dose. And now this 1/10 is arbitrary. You actually need to identify the dose which does maximum anti-angiogenic inhibition. So we developed a model taking into account circulating endothelial cells, circulating progenitor endothelial cells, to identify how could you identify the metronomic dose for any drug, and this model subsequently got published in Journal of Clinical Oncology. Now it's also important that even the studies are partially funded, they can do glamour. And this is an example of another study done by Director at TRAC, Dr. Sudeep Gupta, of neoadjuvant chemotherapy followed by radical surgery. The arm of experimental arm only was the arm which was funded. And this was a negative study, but the point is partial funding also helps. Another study in which partial funding helped was done by Dr. Vedang Murthy, another GCU publication from Tata Memorial Hospital, in which the role of postoperative RT was given. Repurposing is important. There are many drugs which are there for diabetic and antihypertensive, which have anti-cancer activity. And if we channelize them properly, it can be helpful even in conditions which have dismal prognosis like glioma. We finished this phase 1 study, which subsequently got published in Cancer Medicine We have finished arm A2 and B2, which subsequently got published in the Lancet Journal of Clinical Medicine, and this got published just 5-6 months back. We are still recruiting for the arm of temozolomide RT-mebendazole in this for this study. Now, it's important that when you do repurposing, you could do multiple studies, and all these four are for different randomized studies. All are working on the concept of metronomic chemotherapy, which we established in palliative care. We are seeing after doing surgery or after doing radiation in head and neck cancer, can giving this therapy leads to improvement in outcomes or not. And these are simple examples. Examples like oral capecitabine has been shown from China to be good. S1 has shown from Japan to be very good. So we need to keep your eyes open for such metronomic and repurposing things which can be helpful. Cisplatin ineligible patients, cetuximab had to be used in head and neck cancer. Used to be costly. We repurposed docetaxel, and this paper has just now got accepted in the premier journal and would be online. This was an ASCO podium presentation this year, and this established that docetaxel improves PFS and OS. Meningiomas, which are post-surgery, which are post-radiation, multiple recurrence, we are studying whether giving gemcitabine in this patient's health or not. It's recruiting slowly. We have been able to recruit around 11 patients only in this study. It's also important that we understand doses of the drug. Quite a few times the doses, especially for immunotherapy, which have been recommended, are way beyond what are required by the pharmacokinetics and dynamics. And we are studying this because we feel that low doses of immunotherapy can also helpful. This is a major study which is going on in Tata at present of around 800 patients, in which we are trying to see whether low doses of nivolumab help. Does it help in head and neck cancer? It does help in head and neck cancer. This is a phase 3 study which we presented this year. This has got accepted in the premium onco journal and will be online by next month probably, and which showed that addition of dose of nivolumab of 20 mg as opposed to the recommended 240 mg did improve outcomes, and this actually brought down the cost of therapy by 90%. We are working on low doses of bevacizumab also, and this is based on the seminal work of Dr. Rakesh Jain's lab, trying to figure out what dose of bevacizumab in combination with CCNU would be helpful. I'll give you some examples of supportive care also, where studies can be done. Early palliative care, this is a good intervention, but how much it actually benefits. We had evidence in lung, we didn't have evidence in head and neck cancer. So we did a phase 3 study for that. It's also important that sometimes you do some practical approaches. You don't have psycho-oncologist. You don't have so many palliative physicians. Can a physician given palliative care or a psycho-oncological counsel, can it help? It's a good study to answer, because this helps in a lot of ways where fortunately, most of the centers in low and middle income countries primarily think of surgical oncologists, radiation oncologists, and medical oncologists, but supportive care like speech and swallowing, neuro rehabs, or for example, psycho-oncologists are not there in adequate numbers. This was the study which I was talking about video follow-up, and this was done pre-COVID, and this was an idea of Dr. Jalali sir, in which we decided that we'll do video follow-up versus routine follow-up, and it actually showed that video follow-up can be used as for routine follow-up. I would stop here, and what I wanted to make is that investigating these studies can be done in low and middle income countries. You need motivation, you need teamwork, and you need to be smart enough to select your questions. It needs to increase because it is going to solve multiple questions which are relevant, and they need to be encouraged by the institute. I need to thank my funders for this. I need to thank our team. Dr. Kumar Prabhash leads all our efforts with Dr. Vanita Narona and Dr. Amit Joshi. And I need to acknowledge our Neuro-Onco team. Dr. Jalali has left us, which is always there in our hearts and keeps helping us for all our projects. And my colleague Nandini and Dr. Tejpal sir, who helped me in all the projects. And I need to acknowledge my lab partners. Thank you.
Thank you so much, Vijay. It was brilliant exposition of actually how to do it. And you raised several pearls of wisdom for all of us as to how to conduct. And I'm sure this was the point, these were the ideas which Arthur had in his mind when we were trying to conduct this type of exercise. So may I ask my co-chair Pankaj to please introduce the next speaker and the next two talks.
Thank you, Dr. Jalali sir, and I would like to thank the organizers for conceptualizing such a wonderful meeting and a session. It is my absolute honor and pleasure to introduce Professor Tejpal Gupta sir, who's professor and senior radiation oncologist, Tata Memorial Center. He's the director of the Cochrane India affiliate of the ACTRIC Tata Memorial Center. And systematic reviews and meta-analysis are one of his passion, and he's very actively involved in conducting systematic reviews and meta-analysis. So I hand over the stage to Professor Gupta, sir.
Thank you, Pankaj, and thanks to Dr. Syed Atar Inam for having invited me in this very important session. As Vijay, I was also a bit confused what to talk about systematic reviews and meta-analysis, the scope in neuro-oncology. I mean, it's a very vast sort of a topic, but then I thought I would sort of break it down into a brief introduction to systematic reviews and meta-analysis for the benefit of some of the students and fellows in the audience. What is the actual scope of systematic reviews and meta-analysis in neuro-oncology? Some representative examples, some of which we have conducted those systematic reviews and meta-analysis, and some from the indexed medical literature and the impact that they have had upon clinical practice, and finally, summary and conclusions. So we live in the era of evidence-based medicine, and again, this is for the trainees and fellows. Evidence-based medicine is defined as the conscientious, explicit, and judicious use of current best evidence in making decisions about the care of an individual patient. Traditionally, the traditional approach to synthesizing evidence was based on narrative reviews, which were generally written by an expert opinion leader or an authority in the field who would do some Medline search for trials and information, give a brief discussion of the trials for and against, put his inference and conclusion, and that could change or could not influence a practice. Now what we do mostly is something known as the systematic review. The formal definition again is a summary of the medical literature that uses explicit methods to perform a thorough literature search and critical appraisal of individual studies, and that uses appropriate statistical techniques to combine these valid studies. Most systematic reviews evaluate effectiveness of therapy, but as I will show, there are systematic reviews of diagnostic test accuracy, which are also important. Why they are called systematic? Because they are systematic in identification of the literature. They are very explicit in statement of their objectives, materials, and methods. They are highly reproducible in methodology and conclusions. And the best individual source of systematic reviews is the Cochrane Library. We are fortunate to be part of the Cochrane India Network, which is a network of 9 institutions, academic institutions within the country, which is a part of the Cochrane Network in the UK. Now, how are these systematic reviews better than the traditional reviews? Because they have a focused and well-defined research question, clearly stated aims, objectives, materials, and methods. The search strategy is quite comprehensive and repeatable. They use very explicitly predefined inclusion and exclusion criteria. There is always a critical appraisal of quality assessment of the primary studies. There is a clear analysis of the results, certainly qualitative and most often quantitative as well. You can pick up small effects by pooling of data in the meta-analysis. They have a very clear structured reporting format, and they are periodically updated to keep abreast with time. In short, they are much less prone to bias and error. Now, what is a meta-analysis? This term was first coined by Glass in 1976. It is a quantitative synthesis of data to produce a summary estimate, generally done as part of a systematic review. It's a statistical method that combines the results of several independent studies. Again, the formal definition is that a statistical analysis of the results from independent studies, which generally aims to produce a single quantitative estimate of the treatment effect. Now, what actually happens in a meta-analysis? The main outcome is the overall magnitude of the effect. It's not a simple average of the magnitude in all the studies. Meta-analysis gives more weight to studies with more precise estimates. And in general, the weighting factor is always 1 divided by the square of the standard error. This standard error is the expected variation in the effect if the study was done again and again. As a thumb rule, all other things being equal, this weighting is equivalent to the sample size of the study. However, as I said, it is not only the sample size, more precise estimates are, studies with more precise estimates are given a higher weightage in a meta-analysis. So this is how a meta-analysis is generally a part of the systematic review. So how do you conduct a systematic review? You formulate your research question, put together a team. For Cochrane reviews, you need to register the title. For others, it is not mandatory. You write the protocol for the systematic review, locate and select the studies, assess them for the risk of bias, do the data extraction, analyze and present the results, interpret the results, then write the systematic review, then improve and update the review periodically. That is why it is important to do updates of systematic reviews. The Pico approach, Vijay also mentioned briefly. P stands for population, I for intervention, C for comparator, and O for outcomes. So population, what are your study participants or patients? What is the intervention? So the experimental treatment is your intervention. For diagnostic test accuracies, it would be the index test that you are looking at. Comparator is the standard treatment in randomized trials. In DTA reviews, it is the reference standard, could be by biopsy, could be another imaging modality. And outcomes are generally the benefits and harms that you're looking at, either survival or diagnostic accuracy in diagnostic test accuracy reviews. As I said, important to do quality assessment of individual primary studies, and you always have to assess the risk of bias. The Cochrane collaboration has developed this risk of bias tool, which looks at 7 specific domains for randomized controlled trials, which includes sequence generation, allocation concealment, the blinding of participants and personnel, the blinding of outcome assessment, incomplete outcome data, selective outcome reporting, and other potential sources of bias. And each of this risk of bias has to be assessed from the individual primary studies. Now you have a guideline how to report them. The PRISMA, which is the preferred reporting in systematic reviews and meta-analysis. This is the flow chart for PRISMA. It is now mandatory for reporting all systematic reviews and meta-analysis. So you look at identification of studies, the screening of studies, the eligibility, and which studies finally got included in the data synthesis. Now, when should you do a systematic review and meta-analysis? What is the scope in contemporary indexed medical literature? So when the information on overall magnitude of treatment effect is desired, it gives you a mean quantitative effect if you pool data from several studies. When there are several studies asking the same question, but the answers are variable, inconsistent, or contradictory, so you could do a reconciliation of those studies. When there are multiple studies that are comparing different therapies against the current standard of care or the current gold standard treatment, and you want to identify the best therapeutic option. So these are called as network meta-analysis, which are done for comparative efficacy. And finally, when it is required to assess the diagnostic performance of a new test or an imaging modality, as we do in diagnostic test accuracy reviews. Increasingly, systematic reviews and meta-analysis are being used to shape, guide, and inform, if not change, clinical practice. So I'll give some illustrative examples in neuro-oncology, particularly in neuro-oncology. To assess the magnitude of treatment effect, Dr. Vinay showed the SOUP trial, addition of temozolomide to radiation therapy in newly diagnosed glioma. That was a practice-changing study. But if you want to know what is the magnitude of the treatment effect, several other studies, although much smaller than the SOUP trial, have actually looked at this question. And this is a meta-analysis that was done a few years ago. 6 studies that looked at this question of addition of temozolomide to radiation therapy in newly diagnosed glioblastoma. So what was the overall effect of adding temozolomide? Significantly improved outcomes. The overall survival was nearly if you look at the bottom part of the curve, at 5 years, there was almost a 3 times increase in overall survival at 5 years by adding temozolomide. Of course, this did come at a cost of increased toxicity, particularly the hematologic toxicity. So the conclusion was that addition of temozolomide to radiation therapy significantly improves overall survival. However, this comes at the cost of increased toxicity, particularly hematological toxicity. This was published in the Journal of Cancer Research and Therapeutics in 2015. Now, as I said, you might need to reconcile conflicting and contradictory results. We try to look at this question of the role of extended adjuvant temozolomide in newly diagnosed glioblastoma. There were some trials that looked at extended adjuvant temozolomide in newly diagnosed glioblastoma, and this is accepted in neuro-oncology practice. We looked at the efficacy and safety of extended adjuvant temozolomide compared to standard adjuvant temozolomide. There were 4 studies that were trying to answer this question. A couple of them had contradictory conclusions, and we tried to reconcile this data. This is the reconstructed Kaplan-Meier curves of the aggregate data meta-analysis, and as you can see, more than 6 cycle versus 6 cycle, there was no significant difference in outcome as far as progression-free survival is concerned, or even overall survival is concerned. If you look at the forest plots, again, both for progression-free survival and overall survival, there is no significant benefit of continuing beyond 6 cycles of temozolomide in newly diagnosed glioblastoma. If you look at the toxicity profile, so what you can see that the point estimate is on in favor of 6 cycles, but the confidence interval crosses the line of unity. So there's no significant detriment or significant harm in terms of toxicity if you continue the temozolomide beyond 6 cycles. So this is what we concluded, that extended adjuvant temozolomide does not provide any significant benefit, but is also not associated with significant harm in patients with newly diagnosed glioblastoma. If you look at the latest version of the NCCN guidelines, it clearly says in the highlighted in red that there are no clear data that treatment with temozolomide beyond 6 months is beneficial, even in patients with MGMT methylated disease. Very clear that we really don't have any compelling evidence to recommend continuation of temozolomide beyond 6 cycles at the present moment. I was talking about the network meta-analysis, and this is to identify the best therapeutic option when multiple treatments are available that have been compared against the gold standard treatment. So we'll talk about 3 such scenarios: the best therapeutic option in newly diagnosed glioblastoma, the best therapeutic option in recurrent progressive glioblastoma, and the best therapeutic option in elderly glioblastoma. So this is a recent meta-analysis published in Neuro-Oncology Advances, looking at a network meta-analysis of different treatments for newly diagnosed glioblastoma. And this is the network geometry. If you look, the STUP regimen was taken as the gold standard regimen, and a host of other interventions have been compared against the STUP regimen. As you can see on the top part is the studies that have the forest plot is of overall survival. The bottom, the B figure, is for progression-free survival. And excepting for tumor treating fields, nothing really has made a dent. If you look at the progression-free survival, even Bev did show some benefit of progression-free survival, as was mentioned by Dr. Patrick Quinn in his talk as well. What this shows is, this is the ranking, the treatment probability ranking for OS and PFS. So in the methylated cohort as well as in the unmethylated cohort, TTF added to the STUP regimen probably is the best treatment strategy. However, in the unmethylated cohort, this was a bit different. In patients for PFS, it was a bit different. Patients in the methylated cohort stand to benefit both with alkylating chemotherapy as well as immune modulation, whereas patients in the unmethylated cohort, possibly bevacizumab might be the most optimal approach. If you look at recurrent progressive glioblastoma, again, this is from the same issue of the journal. This was published as a systematic review and network meta-analysis looking at recurrent glioblastoma. Again, a host of interventions that have looked at recurrent progressive disease. What the interpretation from this was that there is no standard of care treatment for recurrent progressive glioblastoma, and there are differences in terms of outcomes for overall survival and progression-free survival. So possibly a combination of tumor treating fields and anti-angiogenesis agents might be the most optimal strategy as far as overall survival is concerned. And anti-angiogenic strategy plus a alkylating chemotherapy might be the best approach for improving progression-free survival. If we look at the current NCCN guidelines, again, as I said, there is no standard of care treatment for recurrent progressive glioblastoma, and hence participation in clinical trials is strongly encouraged even by the NCCN. Coming to the last part, which is to look at the diagnostic performance of a test or modality, and we'll talk again about diagnostic yield of extensive systemic staging using FDG PET in primary CNS lymphoma, the diagnostic test accuracy of FDG PET in primary CNS lymphoma, including its differential diagnosis from glioblastoma, and the diagnostic test accuracy of advanced MRI and PET to differentiate pseudoprogression from true disease progression in diffuse high-grade glioma. So this was a systematic review and meta-analysis that we did to look at extensive systemic staging in patients with primary CNS lymphoma. There were some 11 studies that we looked at, and essentially on extensive systemic staging, you find a small proportion of patients with primary CNS lymphoma between 3 to 8%. Our point estimate was 5%. Have systemic involvement at the time of diagnosis, which has diagnostic, therapeutic, and prognostic implications. We also looked at the metrics of diagnostic accuracy of using FDG PET for diagnosing primary CNS lymphoma and differentiating from high-grade glioma and glioblastoma. Again, on the left is the SUV max that you see in primary CNS lymphoma, and on the right is SUV max that you see in non-lymphomas. There were around 16 studies that had looked at this aspect, and we also generated an ROC curve which showed an area under the curve of 0.91. So good diagnostic accuracy of FDG PET in differentiating primary CNS lymphoma from glioblastoma. So what we concluded was that the FDG uptake in primary CNS lymphoma is nearly twofold compared to non-lymphomas, and FDG PET has acceptably high diagnostic accuracy in the diagnosis of primary CNS lymphoma. What has been its impact on clinical practice? The International Primary CNS Lymphoma guidelines that were initially published in 2005 did recommend extensive systemic staging in patients with suspected primary CNS lymphoma, but whole body FDG PET was considered an optional investigation at that time. The currently updated IPCG guidelines recommend a whole body FDG PET to identify systemic non-CNS lymphoma in patients with lymphomatous brain lesions. As far as the brain PET is concerned, they still recommend that the brain FDG PET can be considered optional at this time in primary CNS lymphoma. What is the diagnostic performance of MRI techniques for differentiating pseudoprogression from progression? And this is a systematic review and meta-analysis. And as you can see, the conventional MRI had a poor accuracy in identifying or differentiating pseudoprogression from progression, but advanced MRI techniques such as the perfusion, the DSC, and the DCE MRI had much better diagnostic accuracy. And this is what is reflected in this ROC curve as well. And as you can see, the area under the curve for the advanced MR techniques is more than 0.9, 0.93 for DSC MRI, 0.90 for DCE MRI, and 0.93 for diffusion weighted imaging. So very good diagnostic performance of advanced MR techniques for differentiating progression, true disease progression from pseudoprogression. What about amino acid PET? In the last 5 to 7 years, a lot of work has been done using methionine and PET for differentiating post-treatment change versus recurrence in adult diffuse glioma. At our center, we routinely have been using amino acid PET. We use a combination of advanced MR imaging and amino acid PET as complementary tools to identify progression from pseudoprogression. And Again, this is a systematic review and meta-analysis that has looked at the various amino acid PET tracers that have differentiated pseudoprogression from true disease progression. Again, if you see the area under the curve is approximately between 0.08 to 0.9, which is reasonable. But if you combine this with advanced MR techniques, then you get into an area under the curve which reaches almost 0.95 for differentiating true disease progression from pseudoprogression. This is just the summary receiver operating characteristic curves of all these techniques that have been used using amino acid PET. And as I said, this is a useful complementary tool to the advanced MR techniques to differentiate post-treatment changes from recurrence. What is the impact on practice? The recent EANO guidelines recommends perfusion MRI and amino acid PET might help to distinguish pseudoprogression from true disease progression. So the guidelines also do suggest that you should use advanced imaging techniques to differentiate between these two. What about the best therapeutic option in elderly glioblastoma? And we did this systematic review and network meta-analysis where we looked at the treatment options that have been used in patients with elderly glioblastoma. There were 7 studies that looked at various options in patients with in elderly patients with glioblastoma. This is the network geometry. So we looked at a short course RT, standard course of RT, best supportive care alone, addition of bevacizumab to a short course RT, addition of temozolomide to short course RT, extremely hypofractionated RT within 1 week, and temozolomide monotherapy. So 8 treatment arms that were compared. And if you look at the surface under the cumulative ranking, the SUCRA curve. So the best therapeutic option was the short course RT, the 3-week RT plus temozolomide emerged as the most preferred and the best therapeutic strategy in elderly patients with glioblastoma. This is just to show you the SUCRA curve. So as you can see, the 3-week RT plus temozolomide emerged as the preferred and the best approach as far as elderly glioblastoma is concerned. Not unexpectedly, best supportive care alone was the worst treatment in elderly glioblastoma. What is the impact on clinical practice? So this is again from the most recent version of NCCN. If you look at glioblastoma patients aged more than 70 years, hypofractionated RT with concurrent and adjuvant temozolomide is one of the treatment options for patients with elderly patients with glioblastoma. We all know that there is a significant time lag between publication of a primary study and inclusion in a systematic review, and on an average between 3 to 5 years pass by the time a primary study is published and it is included in a systematic review. And most systematic reviews are themselves become outdated by the time they are published. So the concept of living systematic reviews and living practice guidelines initially proposed in 2014, but I think the COVID pandemic really catapulted it into prominence now. It is mostly defined as a systematic review that is continually updated. It incorporates relevant new evidence as and when it becomes available. It helps to narrow the evidence and practice gap. Living guidelines are an optimization of the guideline development process, and they allow updating the guidelines as newer evidence becomes available. As I said, they have gained immense popularity in the COVID-19 pandemic and are being used and refined by Cochrane collaboration as well as other networks as well. To conclude, systematic reviews and meta-analysis are useful tools to pool and data for synthesizing evidence. They must follow a robust and transparent methodology for conduct, quality assessment, interpretation, and reporting. They are being increasingly used to shape, guide, and inform clinical practice in all medical disciplines, including neuro-oncology, and possibly living systematic reviews and living practice guidelines will become the norm in the future. Thank you for a very patient hearing, and happy to take questions if any.
Thank you, Professor Gupta, sir. As usual, it was a wonderful and comprehensive discussion about systematic reviews and meta-analysis in neuro-oncology. We'll have the question-answer session at the end of the session. And now I would like to introduce our next speaker, Dr. Rupesh Kotecha, who's an accomplished radiation oncologist from Miami Cancer Center, Florida. His special interests are stereotactic radiosurgery, stereotactic body radiation therapy, And he's very prolific in conducting clinical trials, prospective trials involving patient-reported outcome measures, and in therapies using radiation therapy for brain metastasis. So over to Dr. Kotecha.
So I'd like to thank the organizers for the 3rd Annual Neuro-Oncology Symposium for having me here this evening virtually to discuss the role of radiosurgery and immunotherapy for brain metastasis. My name is Rupesh Kotecha. I'm a radiation oncologist at Miami Cancer Institute. So these are my disclosures. Now, traditionally, when we think about patients with brain metastasis, from a local therapy standpoint, and specifically from a radiotherapy standpoint, we would categorize or bucket patients into those who had favorable disease, and those patients typically receive stereotactic radiosurgery in modern clinical practice, and those who had unfavorable disease, and that could be patients who have a poor performance status, progressive extracranial disease, or large volume or number of intracranial metastases, and they would receive whole brain radiation therapy. Now, this scale is very different over time and different based on the countries, as we will discuss at the very end of this presentation. But increasingly in the modern era, we see patients who are at the right-hand most part of this spectrum who are now being treated with systemic therapy agents alone. The goal of my talk here today is to hopefully convince you that radiosurgery plus these modern systemic therapy agents should be the standard of care. To do this, first, I will discuss some of the limitations with systemic therapy alone for brain metastasis with regards to patient selection, influence of prior therapies, tumor biology, the evaluation of the primary tumor versus metastatic disease, evaluating local lesion control, as well as tracking the outcomes of patients who have been treated with systemic therapy alone on other clinical trials. Secondly, we'll discuss some of the advantages of combined modality treatment. So first, with regards to targeted therapies, these are very exciting in the cancer space, but it's important to note that FDA-approved genome-derived therapies actually help a minority of patients with advanced cancer. And often these actually exclude patients who have brain metastases due to inability to cross the blood-brain barrier or not published response rates in certain series. As you can see here, only about 8% of patients actually are eligible for genomically targeted therapies, of whom half will probably benefit from this treatment. When we're thinking about immunotherapy specifically, this is a series that we had put together for SNO a couple of years ago. In our first experience of 150 patients treated with radiosurgery and who received immune checkpoint inhibitor therapy for brain metastases. If you then apply the clinical trial eligibility criteria for the Checkmate 204, the ABC, as well as the Yale Single Institution Therapy Study, all for patients treated with immune checkpoint inhibitor treatments, you see a minority of patients actually meet this clinical eligibility criteria in a very busy academic practice. And so for this potentially does not actually correlate or is associated with the responses that we see in clinical practice. Now let's look at the responses in clinical trials. So the most commonly cited data is for melanoma brain metastasis treated with dual immune checkpoint inhibitor therapy. And here we've seen significant response rates compared to historical data with chemotherapy alone. For example, we have data that supports potentially a 56% response rate with dual immune checkpoint inhibitor therapy in this patient population. It's important to note, though, let's think about the categories of patients that we actually see in clinical practice. What if a patient is not a candidate for dual immune checkpoint inhibitor therapy? Well, the response rates with nivolumab alone are much less at 21%. What if a patient has had prior BRAF/MEK inhibitor therapy? Well, even with dual immune checkpoint inhibitor therapy, the response rates are only 16%. What if a patient has symptomatic disease? We think about these high 50, 60% response rates, but that's actually for patients who have asymptomatic disease. Patients who are symptomatic have much inferior response rates at about 22%. And then finally, what about those patients who are on dexamethasone corticosteroids for symptoms associated with their intracranial metastatic disease? Again, poor response rates at about 17%. A second consideration is that there is potentially a discordance between PD-L1 expression between primary tumors, brain metastases, as well as tumors infiltrating lymphocytes. In fact, this is a systematic review of the literature that we had performed last year that showed about 20% of brain metastases actually express different PD-L1 expression levels than matched primary tumors. This is important given the data that we have for extracranial responses and correlation with PD-L1 expression. And then finally, let's track the outcomes of patients treated with systemic therapy alone on these clinical trials. One of the pivotal studies was the phase 2 study of Pembralism alone for non-small cell lung cancer or melanoma brain metastasis that was performed at Yale. In this study, there was a 26% CNS response rate for lesions up to 2 centimeters in size, a cutoff that was actually revised after the first patients were initially enrolled and ultimately actually required surgical intervention. Now, the primary highlight for this study was the median overall survival of 17 months, and really with the statement that 48% were still alive at 24 months after starting that study. Well, let's actually look at what the data in the details actually showed. Well, we had 3 categories of patients. The first were 7 patients who actually never needed local CNS therapy. What happened to those? Well, 2 responded to systemic therapy alone, but 5 ultimately died rapidly of systemic disease progression. So they actually never became eligible for local CNS therapy, such as radiation or surgery. Second category of patients were 7 who had radiosurgery or surgery and then enrolled onto the study. 2 of those actually died during the study, and 5 still needed salvage local therapy despite having local therapies before going onto the study. Of these, only 2 completed the trial. And then finally, the last 9 patients. This is basically a clean data set. Those patients actually entered the trial without any prophylactic local therapy. Well, what happened to those 9? All 9 actually needed salvage local therapy, and only 2 completed the trial. So again, with follow-up of these patients and detailed analysis of what happened to them, we can see the lack of local therapy upfront is still needed actually at the back end for these patients. And let's look at another disease site. This is a phase 2 study of Devolomab alone for renal cell carcinoma brain metastases. All patients actually had asymptomatic disease at their trial enrollment. 5 actually didn't even respond to treatment. They experienced rapid clinical progression and passed away before their next MRI scan. This is a specific concern for a brain metastasis patient population when we're withholding local therapy, as disease progression can cause a patient who is asymptomatic to then result in rapid clinical progression and then potentially need more significant interventions such as surgery. 50% actually developed symptoms related to the treatment with systemic therapy alone, and the intracranial response rate was only 12% in the cohort of patients who did not receive prior local therapy. In fact, in this study, 50% experienced intracranial progression as their best response on the study. And finally, it's important to note that there may be this concept of total intracranial burden, and this may be associated with control rates with systemic therapy alone, as no objective responses were observed in those who had multiple lesions or those who had lesions that were more than 1 centimeter in size. So I'd like to contrast all of those limitations that I just presented with some of the advantages for combined modality treatment, which is radiosurgery and modern immune checkpoint inhibitor therapy. I think the timing of therapy can improve local lesion control. It can reduce distant cranial failure risk. It is a safe and effective combination, and potentially this combination, when used in the upfront management of these patients, may drive an overall survival benefit in our population. So as we know, the limitations with radiation therapy alone is that it causes a modest local tumor response, but essentially weak or no abscopal effect in the rest of the brain. So distant intracranial failure continues to be an issue, especially with focal therapy alone. I will contrast this with the right-hand side of this figure. When we use radiosurgery and immune checkpoint inhibitor therapy at the same time, we potentially can cause a stronger local tumor response, as well as a strong abscopal effect in the brain. Well, let's review the clinical data. The first advantage for a combined modality treatment is that it is associated with improved velocity of response. Here are essentially 2 graphs that show lesion changes over time. The first is in patients who received radiosurgery and non-concurrent immunotherapy. And then if you look at radiosurgery and concurrent immunotherapy, you see a faster reduction in lesion volume or velocity of response to treatment. In fact, at that 6-month mark, about a 90% reduction in lesion size as the median response. The second figure actually shows how this is more dramatic in patients treated with radiosurgery and anti-PD-1 therapies compared to CTLA-4 therapies. The second advantage is that radiosurgery and anti-PD-1 therapy is more effective than our traditional outcomes or historical rates with radiosurgery and anti-CTLA-4 therapy. In this series, there was a benefit seen with regards to local disease control, so better local control with nivolumab versus ipilimumab when timed with radiosurgery. But also there was a suggestion of better control of distant intracranial sites with a reduced risk of distant intracranial failure with radiosurgery and nivolumab compared to radiosurgery and ipilimumab. The third point is that radiosurgery and concurrent immunotherapy is associated with improved response at that first follow-up. So I mentioned a majority of patients are actually symptomatic due to their disease, and therefore significant and substantial reduction in lesion size as quickly as possible is clearly advantageous. This is a comparison done at Memorial Sloan Kettering of patients treated with radiosurgery without immunotherapy. I would focus on the complete response rate for these waterfall plots. It's actually about 4% of patients have a complete response at their first MRI, which is a median of 8 weeks after treatment with radiosurgery alone. With radiosurgery and ipilimumab in that era, it was about 13%. And then if you look at radiosurgery and pembralism, it jumped to about a 35%, or 1/3 of patients having a complete response at their first MRI scan. This is a series that we had put in the literature, which is 150 patients treated with stereotactic radiosurgery and immune checkpoint inhibitor therapy to over 1,000 brain metastases. Each of them are coded here on this waterfall plot. This is an individual lesion-based response. As you can see here, the complete response rate, very similar to the previously presented data from Memorial Sloan Kettering. About 1/3 of lesions actually in this series have a complete response. And immune checkpoint inhibitor therapy delivered with radiosurgery increased the rate of complete response, as well as increased the rate of any response around the time of radiosurgery. In fact, I would actually compare this to a recent systematic review of the literature, which was published in JTO, which looked at the response rates with immune checkpoint inhibitor therapy alone for patients with non-small cell lung cancer brain metastasis, not treated with prior local therapies. And in this pooled analysis, as you can see here, the weighted response was 16%. That is essentially the failure rate in patients who receive radiosurgery and immunotherapy at 14% in our series, a majority of whom were actually non-small cell lung cancer. The next point I'd like to make is that radiosurgery, when timed with immunotherapy, does reduce the risk of distant intracranial failure. I know I've shown previous slides comparing this to CTLA-4 therapy, but specifically if you look at radiosurgery alone, timed with immediate immune checkpoint inhibitor therapy versus delayed immediate immune checkpoint inhibitor therapy, you see a fewer number of new intracranial lesions, as shown here in this figure on the left. The figure on the right actually is also descriptive of the same phenomenon. As you can see here in this melanoma brain metastasis patient population who received radiosurgery alone had a higher risk of distant intracranial failure, or in this case, a low rate of distant intracranial control. Interestingly enough, patients who received radiosurgery and combination BRAF-MEK therapy, which does have significant intracranial penetration and response rates, they also had a poor distant intracranial failure rate, similar to that with radiosurgery alone. But radiosurgery and immune checkpoint inhibitor therapy had a reduced rate of distant intracranial failure, or a better distant intracranial control rate. That was superior to that of radiosurgery alone or radiosurgery and BRAF and MEK therapy. And finally, if you have all of these advantages, is there potentially a risk with combining radiosurgery and immune checkpoint inhibitor therapy? Although some of the initial series did publish some concern for an increased rate of radiation necrosis, there have been multiple large series, including our study, and then a meta-analysis of literature, which did not reveal a significantly increased rate of radiation necrosis. In this meta-analysis, the pooled rate was 5%. Finally, we are doing some research to determine which subgroups of patients potentially benefit even more from immune checkpoint inhibitor therapy around the time of radiosurgery. So this is stratification of our non-small cell lung cancer patients based by their KRAS status. And you can see patients with KRAS mutation actually benefit substantially from that timing effect, less so for patients who do not. So we're still learning more about the biology as well as the timing of these agents. But based on the analysis of the data to date, I present to you this very nice real-world data set from 23 German skin cancer centers. 380 patients, 31% of whom were symptomatic, and 2/3 had a BRAF mutation. If you look at overall survival for all of these patients, systemic therapy alone are patients who received dual immune checkpoint inhibitor therapy, the best systemic therapy that we have, versus those patients who received that plus received local therapy at any time. You can see a substantial survival difference, 16 months versus 24 months. Now, if you then look at those patients who received upfront local therapy versus salvage local therapy, that's essentially recapitulating those same survival differences. So that local therapy does appear to provide a survival benefit and has really been driven by upfront treatment. And so this has supported this current paradigm. Obviously, this needs further validation in, for example, a randomized controlled trial, which we have been attempting to put underway. Now, switching gears to the last part of my talk, I was asked to touch on how we develop and offer these types of modern radiosurgery practices in low and middle income countries. So essentially, there are three large barriers that I think to offer modern radiosurgery practice. First is that most of these countries actually have a low allocation of their GDP towards healthcare, despite significant economic loss due to cancer morbidity and mortality. For example, if you take India, the total healthcare spend was 1.29% of the GDP for the country, yet cancer burden alone, outside of other healthcare expenditures, actually accounts for almost 0.5% of GDP loss. Second is that there's reallocation based on geography and financial support. For example, again, with India, 40% of top cancer centers are actually located in major metropolitan cities, and 85% are actually under non-governmental ownership. The second barrier is that for modern management of patients with brain metastasis, access to radiosurgery technology is unequally distributed throughout the world. So for example, there's one dedicated radiosurgery unit for every 10 million people in Europe, North America, and Australia. But in South America or other countries, it's potentially 35 million people per device. And those devices are not always up to date and are not dedicated to intracranial radiosurgery specifically. And finally, access to education about radiosurgery technologies is also limited. There was a recent survey about programs, and the identified barriers were lack of training, dosimetry protocols, communication, and organization about the process. So how do we offer modern radiosurgery and combine it as immunotherapy is becoming standard of care throughout the world? Well, I think all of the solutions can be divided into two categories: those that assess radiosurgery quantity, and then second is those that address radiosurgery quality. To address quantity, there should be installation of radiotherapy machines and potentially those that can do radiosurgery and other disease sites as those machines are coming online and on the market. There needs to be an increased capacity for workforce training, and that includes not just physicians, but for radiosurgery, physics, dosimetrists, and advanced radiation therapists. We need to build new infrastructure that can support these radiosurgery platforms, and that infrastructure requires resource allocation as well. Now, local subject experts should be incorporated into these policy-making decisions, as well as with these resource allocations, because they have the specific knowledge about what needs to be done to practice radiosurgery and what is needed in a building. We need to develop national cancer programs that recognize radiosurgery requirements and standardize the processes, provide in-country and level support for operating newly set up infrastructure, and continually reevaluate ground-level radiosurgery volumes and estimates, as well as needs, and then recalibrate based on what those change over time. To address quality, we should build technology with up-to-date radiotherapy infrastructures. This changes constantly over time, and so this is an area that needs continual enhancement and upgrades. We need to upgrade existing radiotherapy technologies to include radiosurgery delivery capabilities, whether those are the installation of high-def MLCs or additional imaging capabilities. We need to train existing personnel for these new technologies, as well as potentially hire experienced personnel for programmatic growth in certain regions. We need to ensure quality assurance checks for implementing new radiosurgery delivery technologies, provide continuing education experience as volume and caseload grows, and as new evidence develops, as we develop new fractionation schemes. We should invest in public and private partnerships to help invest in new technologies, as well as develop a hub and spoke model for improving access to high quality care for specialized techniques. This has been done throughout a number of centers in India with great success. We should strengthen referral systems and provider networks to ensure adequate patient triage for advanced radiosurgery treatment, and provide educational exchange programs and access to telemedicine networks to enhance training and support, which has been done throughout the African continent. So hopefully, in conclusion, retrospective evidence does support the role of combining local therapies, such as radiosurgery, along with modern immunotherapy regimens with regards to velocity of response, higher rates of complete and partial lesion response and control, durability of local control, and a reduction in distant renal failures. This is done safely with low rates of radiation necrosis. Now, together, these may be driving an overall survival benefit in the patient population, but prospective comparative evidence is clearly needed to help optimize patient selection, timing, sequencing, and fractionation schedules. Finally, as this expands throughout the rest of the world, the radiosurgery space does require several action plans to address radiosurgery quantity and quality to allow patients with brain metastasis throughout the world to receive this high quality care. Thank you.
Thank you, Dr. Kotecha.
Okay, thanks, Pankaj, and thanks everyone for brilliant talks. I'm told we don't have so much time, but I think the session does require some discussion. So may I take the prerogative to start with Dr. Wen, and he's been patiently. Thanks again, Patrick, for waiting for long and listening to all the talks. I just have two brief questions, and maybe that will set the ball rolling. First is, there is quite a bit of data now, certainly for the last 10, 15 years in our practice and many centers in the world, and I appreciate the differences in standardization. But the perfusion technology, the diffusion weighted, is becoming more and more standardized and kind of adopting a so-called standard platform. And there are 2 or 3 vendors only throughout the world. How soon do you think RANO would incorporate? To me, it appears to be a very important endpoint and will clear a lot of issues that we have in response assessment criteria.
Yeah, that's a great question. So the problem is that in updating RANO, we wanted to do it based on data. And there's no definitive study that clearly shows perfusion makes a difference. So we actually gave up data sets, the 500 something newly diagnosed and 500 something recurrent patients, to Kathleen Schmader, who is an expert in perfusion. And we're hoping that she can analyze that data and show definitively that it helps. And I think if it helps, we want to put it in the criteria. But right now, the data is really not strong enough. I think the other challenge with perfusion is that everybody has their own technique. So there has been a standardized perfusion protocol that was published a year or 2 ago from Reno. And I think hopefully people will adopt it, because if you use different techniques at different centers, then that also makes it very hard to compare scans. So I think we want to do this, but I think we don't want to do it just because it might work. We want to do it based on data.
Sure, thank you. The other question is, of course, now the 21 especially classification, it differentiates GBM into so many different cohorts. Now, if you talk about Stoop's time, there was a central path review, and so was the case in subsequent studies, but the central path was just glioblastoma. They had to have pseudoparasitic necrosis, there were classic morphological types, but now you can have an IDH mutant grade for astrocytoma without necrosis or microvascular proliferation, to otherwise looking as a grade 2, but histone driven, either G34 or M27M, H3K27M, again a GBM, and then you have EGFR directed therapies. So EGFR directed diagnosis. So it's becoming a little bit more difficult. And then you already have so many challenges in conducting appropriate trials with so many different endpoints. How do we tackle this whole conundrum?
I think the 2021 classification, it is actually very helpful, because if you look at all the gliomas, it shrunk it, at least in adults, to just 3 groups. So that in some ways makes it easier. You have the IDH wild type and the IDH mutated. And so in terms of trials, it becomes easier. The one category that's problematic are the low-grade gliomas histologically that are IDH wild type and so behave like glioblastoma. You know, the idea is that we should treat them like glioblastomas, but we actually don't know if that's the right thing to do, because from at least 2 different trials, it seems like they don't respond to temozolomide, which is surprising, but you know, it could be that their behavior is very different. So there's some efforts underway to collect data internationally to try to see if these molecular GBMs are really the same as histologic GBMs. So I think that the new classification is in advance, but there's still a lot of things that we need to figure out.
Okay. I just have one last question to Rupesh Kotecha before he goes, and then we can have other people join in. Rupesh, what is the latest status of neoadjuvant radiosurgery in brain metastasis? I know there's been a lot of talk and there's a couple of trials going on, but outside the trial, is it becoming very popular in the United States, or do you have any idea how the field is likely to move in the next few years?
So you mean neoadjuvant radiosurgery for operable brain metastasis? Yeah. So, you know, there have been a number of data sets that have supported that neoadjuvant or preoperative stereotactic radiosurgery is advantageous compared to postoperative stereotactic radiosurgery. We've known from a radiation oncology perspective, it's easier to delineate the target itself. In the preoperative setting, you're just targeting intact tumor. And also you can ensure that basically 100% of patients are getting the radiation because they're all being treated before surgery. If you look at post-op SRS series, there's about a 25% dropout that's typically seen. If you actually collected all of the patients who had been eligible for post-operative radiosurgery, but never made it because of functional decline, going to rehab, and just not following up. So you do lose those patients. But outside of the logistics, the data so far in comparative retrospective analyses have shown at least similar, or some have shown better local control. There has been a reduced risk of radiation necrosis, and there's been a reduction in risk of leptomeningeal dissemination after the treatment. And so there's an ongoing prospective trial that actually just activated, I think just this last week, NRG-BN12, which randomizes patients to preoperative stereotactic radiosurgery or postoperative stereotactic radiosurgery. At our facility, you know, we had transitioned to preoperative radiosurgery about 4 years ago based on the retrospective data. And we are looking at the histopathological features that occur after in the biology of the brain met after you do radiosurgery. So I think it gives us some ability to evaluate this tissue and the effect of radiosurgery. We had recently put out our experience in paper, our 1-year local control with a median tumor size of 3.6 centimeters, so large brain mets, with what we call as dose escalated pre-op radiosurgery, which is typically a 3 grade higher than what we traditionally do. Our 1-year local control rate is 95%. So they're very exciting outcomes. And we'll be presenting, it's no later this year, a comparative of preoperative SRS versus postoperative SRS versus fractionated SRS, or even staged SRS. It's 100 patients. And so far, preoperative SRS followed by surgery actually had the best local control rate. So we're now looking at this in a larger series of 300 patients and collecting the data right now. But at least that's our preferred management approach at our facility.
Very nice. Actually, we have also changed our practice to some extent. I'm increasingly excited to do the preoperative SRS, but you have to have a good core relationship with the neurosurgeons because the timelines are important. And at the Proton Cancer Center, we have established that protocol. And also the volume is so much smaller than the post-op volume because you end up treating such a large volume and invariably fractionated, which could also be a potential challenge. So thanks very much for those insights. I'll hand over to my colleague, Dr. Inam, who is the main person behind all the conference and the movement that he has started in Pakistan. So Dr. Inam, please go ahead with your comments and also any audience questions.
Thank you. Well, so I just wanted to thank everyone, including those, I think Vijay left, right? So Dr. Pudavali,
Vijay is there. Vinay had to leave.
sorry, Vinay had to leave because of the his work. So thank you very much. Dr. Patel, your talk was just an amazing talk. I think there'll be a lot of students going through that talk again. So I'm going to put you on a spot right now. A year ago in 2 annos, Dr. Patrick Quinn, we talked to him, it was a similar kind of session. And out of that came out some ideas, which a few residents and students at AKU followed. And now we have a clinical trial. It's waiting for the ERC approval. So Hamza Bajwa is working on that one, few of his colleagues. And as soon as the ERC gets approved, we will proceed with that. Do you mind if we have a group of students and residents get in touch with you? And if you can work with them, give them ideas, coach them, it'll be a wonderful thing, a collaboration between ISNO and PASNO at the world stage. So I'm putting on a spot, Dr. Vijay Patel, but what do you think about that? You're mute, I think.
I don't mind. They can contact me. No issues. I like them.
So I did ask Rakesh before I asked you, but Rakesh has a very high opinion about you, and he's very happy to see you and Tejpal doing so good in your career. So you have any questions for Dr. Tejpal Gupta? Pankaj, do you have any question on there?
Yeah, I have a question for both Dr. Vijay Patil sir and Dr. Tejpal Gupta sir. I would like to ask you, like, how difficult or how adventurous has the journey been from getting research across to global platforms? I know TMH has been doing great recently, but how difficult has the journey been, and how difficult has it been to publish our studies in high impact factor journals like JCO and Lancet? So how gradual and how difficult has the journey been?
I'll let Dr. Tejpal sir go first.
Tejpal, or you, who's answering this?
So Pankaj, I think the very fact that you spend so much time at Tata Hospital, I think it happens automatically. Of course, you need to put in a lot of effort. I think publishing in high impact journals is sort of bias against the LMIC countries as far as data integrity and data authenticity is concerned. I mean, it is viewed with some suspicion, but changing, and we are sort of publishing in high impact journals. Certainly in the last 10 years, I think a whole lot of studies from Tata Hospital have made it to the big journals. So I think the place itself gives you that sort of opportunity and even inspiration to excel, and that's what we aspire to do. Vijay, you are the celebrated sort of publisher. So
I think I worked in Malabar Cancer Center before coming to Tata, and I agree with him. The name of Tata actually carries a weightage. So the same paper, if you comes from another part of the country, it doesn't carry that weightage as it comes with Tata Hospital. So that is an added advantage you get. Second is it takes time, Pankaj. At least I failed in multiple of my studies, didn't went through for high impact journals initially, but slowly I could see the I remember 2013 was the first year I got in oral oncology, which had an impact total of 4 at that time. I was very happy. Today I must have at least 2 dozen plus papers in oral oncology, but that is the way it is. And 2000, it took quite a bit of time for us to get our first JCO. It actually came in 2017, but after 2017, a lot many has come. So I think, at least in my experience, getting the first breakthrough, it's also difficult. Sometimes we are not very clear about what exactly the editors are looking for, what exactly the reviews are looking for. You would see that with multiple comments, multiple papers, if you see the same paper which you published a decade ago, you would realize that, oh, I had made multiple mistakes. we always think that there is slight bias, but we also make those mistakes. And I would say that those are the beginner's mistake which you make. The same paper, when you see after 10 years, you would say, okay, I would have written it differently. I would have uh, uh, drafted it differently, would have given more analysis here. So I think evolution does happen, but it takes time. You need to go through that evolution.
May I just take a moment to ask Patrick? Patrick, you have been the editor of Neuro-Oncology and in such major journals over a period of time. Now you can see a perceptible kind of a growth and enthusiasm in some parts of LMICs, and Vijay actually demonstrated quite well how to choose the study, what are the pitfalls, potential pitfalls, and navigate through them. As a global neuro-oncology researcher, what is your advice? How should we bridge it, and how the high income countries can help in this regard as well? I think you might be mute, Patrick. Sorry.
Mute,
Sorry, the two things that I think do make a difference is the importance of the question. So for instance, the mebendazole study that was mentioned earlier, everybody actually is interested in that result because all our patients ask us, does mebendazole work? And so the question is important, and also just the design of the study. You know, that there is bias, and reviewers will look to see who's writing it, and they'll give a pass to people who had a good track record. But if the design is robust and the data is interesting, then it will get into good places.
Okay, thank you.
I have a question for Professor Patrick Wen. Professor Wen, thank you for an amazing talk on patient-reported outcomes. I would like to ask how important or critical it is for patient-reported outcome tools to be developed regionally and geography-wise also, because many times we are faced with non-compliance of all the questions in a patient-reported outcome tools geography-wise. So how critical it is to have individualized as per the region, the tools?
Yeah, I think it's a really important question. You know, even the ones that are commonly used now are really flawed, and there really aren't great tools for neuro-oncology. And so in some ways it's an opportunity to develop better tools. So it's a huge gap in our field.
Okay, so great. Thank you very much. And the audience want to thank you for your time, your expertise. And we will, yes, go ahead.
We have a couple of questions from the
Oh,
audience.
we have a couple of questions.
Oh,
Well,
okay.
so I don't mind. I mean, you know, looks like I was just worried about you guys. If you have questions, you know, I'm sure Dr. Wen and Rupesh and Vijay and Deshpal, they are all okay with that. All right, go ahead.
Okay.
I don't know.
So that
I was just concerned about the audience. That's all.
all
All right, go ahead.
Can you hear us? Okay.
Yeah.
So that was an excellent session, and we really enjoyed your talk. So I would like to ask Dr. Patil one thing, that I would like you to, how important it is for the healthcare professionals working in LMICs to develop the trials, clinical trials. If you look at the data, around 80% of the randomized controlled trials, especially if I'm being focused on neurosurgery, are being done in high-income countries. Majority of the population living in low and middle-income countries. So if we are really going to utilize those resources, like you mentioned in your talk, that we don't have protected time, we have less resources. If we are really going to use all those resources, how can we channelize? How can we prioritize the questions that we should start with? So because you might find many enthusiastic, professionals here, but we don't want to waste those resources as well. So as an expert, like for the clinical trials in LMIC, what will be your take on this? Thank you.
Yeah, so I think doing research is the basic duty of oncologist. If your outcomes, let's say at 5 years, are 30%, if you don't do research, if you don't think out of the box, whatever service you give, the outcomes will be 5 years at the best 30% or below that. So if you want to improve the outcomes to say 40%, 50, 60 or 70, you will have to do research. So according to me, it's the basic duty of any physician, especially who is working in an academic center or tertiary care center, that he does research. Second is what kind of questions do you want to focus on? Now, the thing is that the way we look at it at Tata and our groups look at is, we focus on those kind of interventions which could be available to our patients from the, if let's say that if we present the results this week, they would be available to our patients from next week itself. Like for example, I would, if I get a choice to do a study on, let's say, neoadjuvant pembrolizumab versus giving neoadjuvant mebendazole, the researcher part in me would like to take the study of neoadjuvant pembrolizumab, but I would still prefer to take the question of neoadjuvant mebendazole. The reason being that I know that if mebendazole study succeeds, this is a molecule which can be used by my patients from next week onwards. It's easily available and it is not out of accessibility. So for me, that the simplicity of the intervention and the accessibility of intervention plays its much higher over science, because it's practical. Because even if I do the study, even if I prove that neoadjuvant pembrolizumab works, frankly, in my country, only 2% of the patients are going to afford it. If I put another repurposing drug there, and if I show that it works, or if I find that it works, it would be applicable. It may not be as good as pembrolizumab, but it might be applicable and accessible to a large majority of the patients. That is the way my thought process goes. It might be right or wrong, but that is the way I think it's more logical to do in LMIC.
Thank you.
Hi, my name is Hamza Bajwa. I'm a current resident in neurosurgery here at Avalon. Dr. Patel, I really loved your talk. It was very inspirational, especially for early career investigators, people trying to get into developing these sorts of high-level studies for LMICs. What I really wanted to know is that what have you at your center, how have you been able to deal with attrition, especially that's common amongst patients that are being recruited for trials in LMICs, that we're facing the same sort of issues for studies here in Pakistan as well? Thank you.
Could you repeat the question? I couldn't get the question.
Oh, sorry. How are you dealing with attrition in your clinical trials and loss to follow-up, especially within our sort of setups?
Okay, yeah. So this is we learned it the hard way around. So initially our attrition rates in our studies used to be 20 to 25%. It still today stands between 5 to 10%. One of the things we assess is how far the patient stays from the center, and we assess the compliance, how likely is it come to them. Basically, we assess that how many relatives are there with the patient who could take care of the patient at the hospital and they could commute the patient back to the hospital. Attrition becomes essentially more problematic when you are doing studies in palliative setting, let's say like palliative head and neck cancers or palliative gliomas. If studies which are there in curative setting, many of the times you'll see that most of the patients get cured, so they do come. The thing what I've seen in curative, so I'll first discuss on curative setting. The attrition in curative setting starts after 2 or 3 years, most of the times when the patient starts feeling comfortable that further follow-ups, they try to miss these follow-ups. Where we have been able to overcome is that we counsel this. So what we do is the study patients, when they come for follow-up, we give them preference and we see them first. So follow-up patients are seen initially in the OPD, and then they are allowed to go first, so that eases out their time at the hospital. Second is, if they miss the follow-ups, I told you that it's good to keep a calendar of which patients are coming to come. A reminder call is made to them by the coordinator, and if they are unable to come for the follow-up, we actually do a video call with them now and try to get as much as information on the video call which would be possible, and we try to motivate them to come and see us. That's the way we do it in curative setting. In palliative setting, actually, when you do if the patient doesn't come to a follow-up, most of the times he has some issues. a video call done to the patients or a telephonic call done to the patients helps out a lot of times, especially like when I do studies in head and neck cancer, a lot of them are in pain or have problems with respect to dysphagia and nutritional issues. When you start starting these problems with them on a video call, and a lot of time, yeah, with our social workers, even see that we courier the medications to these patients because they would be in a village or a rural area where they don't get this. They actually develop a very good relationship, and these patients then would like to keep doing those follow-ups with you even if they physically cannot come. So this is the way we actually try to overcome, but it's still there. 10% of the patients still we lose, but it's also boils down to your selection of patients you know who have been non-compliant, who are not when you do screening tests, they don't come on time. It's better to avoid such patients.
I just had two more points. It's a great question, so relevant to our landscape. And one of the things, like 20 years ago, when we started the Neuro-Oncology clinical research program, was there were no, these cell phones were just beginning to start. The Brain Tumor Foundation of India really helped. And now you have, Dr. Inam has the very great support from the Pakistan Foundation also. So they employed several coordinators who were tracking these patients. Selection of the patient is very, very important, as we just said, and also pragmatic style. For example, the baseline, the neurocognitive and neuroendocrine testing, we did only once a year. It was enough, but at least it was done very well. The repeated imaging, you don't need to do so much imaging as has been prescribed in many of these settings. And then we also, in 2008, 2009, I remember when the cell phones came, we started giving them SIM cards for free until they became so cheap, actually they were started giving back to us. So there are several strategies that you have to adopt over a period of time. But I have to say it needs a little bit extra care, selection of the cases, persistence, some dedicated people out there to motivate them, extra staff, some luck also to some extent. And once you get that model successful, I think then it becomes easier. The initial bit is the hardest part.
Thank you so much.
Yeah, I just have short two questions. Hello, I am a final year medical student, and also my first question is for Dr. Gupta. Hi, Dr. Gupta. I'm also a trainee in the Cochrane mentorship program. So as you mentioned that meta-analysis have to be living and they have to be kept on being done. I've seen several topics which have many trials. I understand that there are different trials with different results, but there are trials which have very similar results. And then again, there are meta-analysis being done for the same thing again and again. For example, there's this topic on phthalates and neurodegenerative diseases, neurodevelopmental disorders. So what's your opinion on that? Should you continue repeating the same results again and again, or should we move forward to something else? And my second question was for Dr. Vinay, but since he's not here, so I think anyone can answer this. So the studies that Dr. Vinay showed, all of them, most of them had one factor which I noticed, that the corticosteroid use was associated with a worse outcome. And I've seen this in several other studies as well. However, steroids use is a very, very common practice in neuro-oncology in general in oncology. So do you think we should have some guidelines or limitations to that? Thank you.
Yeah. Thanks for asking that.
She's just a medical student.
Yeah. So I think as far as meta-analysis and systematic reviews are concerned, of course, their use has increased significantly in the last 2 decades because the methodology has become more robust. People are more sensitized to it. The more important thing is to reconcile when you have conflicting or contradictory results from the trials asking the same question, but nothing stops you from meta-analyzing data if you have 5 trials which give you the same direction of effect. So say the Temazolamide meta-analysis that I showed, all the 6 randomized trials actually showed that there was a benefit of adding temozolomide to radiation therapy. What you do by pooling all the data is that you get a sort of more crystallized picture, and these trials were done in different settings. It's not only the EORTC NCIC trial. One trial was done in Egypt, one trial was done in Poland, one trial was done in some other countries. So when you have trials from different settings, different say high income country, low income country, low middle income country settings, it does give you a more crystallized picture. So I don't agree that you should not do. Of course, practice will be changed by a large definitive pivotal randomized controlled trial. Generally, meta-analysis are not going to change practice. They can shape practice, they can inform practice, they would not really change practice. But a large, well-powered, well-conducted, randomized controlled trial is the one that would change clinical practice.
Rupesh, you want to take the steroid question?
Sure. So, it is an issue for our brain tumor patients that they typically require some level of corticosteroid dose. I mean, for the patients who have, for example, a gross total resection, I mean, we very rapidly taper their steroids. And even for the patients who have a subtotal resection, as they start radiation therapy, we do taper their corticosteroid dose as much as possible. So during the course of radiation therapy, they're on the least amount of steroids for the least duration of time. There are patients who towards the end of treatment may require corticosteroids, but we have kind of a higher threshold to offer to patients, especially if they're going to be on clinical trials involving newer vaccine therapies or with immunotherapeutics. In our study on brain metastasis and immune checkpoint inhibitors, we saw the same effect, actually, a reduction in response rate, PFS, and actually OS for the patients who required corticosteroids when they were treated with radiosurgery and immune checkpoint inhibitor therapy for their brain metastasis.
I just wanted to make a comment on this. I think the message should be that steroids should not be used electively in brain tumor patients. They have to be used judiciously for symptomatic patients. A whole lot of radiation oncologists, neurosurgeons just give steroids post-operatively and even during radiation therapy. So that is something that should be completely avoided. You should not use steroids prophylactically or electively. Only when the patient really needs steroids, you should use them.
Yeah, I completely agree. Actually, probably the first thing that we do whenever the neuro-onc or rad-onc team picks up a patient, we see this more with brain metastasis because we pick them up from, for example, medical oncologists. Literally, the first thing we do is actually taper or discontinue their steroids. So you will see patients that come to us with a 4 millimeter brain met with no vasogenic edema, and yet they were started on corticosteroids by their medical oncologist. As soon as they got a call that the patient had brain mets from, the radiologist, they would start the steroids and send the referral in. And so that's why in our process, we try and see that patient right away, because the first thing we can do is discontinue their steroids.
Actually, Pankaj Panda, who is here today with us, along with several of us, actually we ran a nationwide throughout the country, a survey about the corticosteroid use in brain tumor patients, and had such interesting, very diverse. It was anonymized, so people could write whatever they want in the practice. And if the student asked a very brilliant, both the questions were very nice. So if she would like, then Pankaj will be happy to share that paper with her to tell us the real kind of a real life scenario as to the use of steroids. So any other comment or question, Akhir, or would you like to close the session then?
No, I don't think we have any more questions. I just want to thank all of you. And, Patrick, you saw this thing coming up, for the last 2 years. And Rakesh, you have been support along with Pankaj. So I hope to work with the rest of you guys also and take it forward. I'm really grateful to all of you for helping us build up this thing in neuro-oncology in Pakistan. Thank you.
Congratulations on a really wonderful meeting.
Thank you.
Have a good evening.
Thank you all for tuning in for the session 11 of the third annual Neuro-Oncology Symposium. That also brings us to the end of the second day of the third annual Neuro-Oncology Symposium, and we'll continue tomorrow from the student abstract presentation at 9 a.m. Thank you.